land acknowledgement, or is it on anybody else's?
Like, we'll switch the screen in just a second when we start the recording.
Oh, we can start it.
They're starting it now.
Oh,
Is it going?
it's good.
Okay.
Is anyone interested in reading this?
I'll read the land acknowledgement.
Okay, Andrea's gonna read it.
Fuck.
Land acknowledgement. The San Francisco Department of Public Health staff acknowledges that we are on the unceded ancestral homeland of the Ramaytush Ohlone, who are the original inhabitants of the San Francisco Peninsula. As the indigenous stewards of this land and in accordance with their traditions, the Ramaytush Ohlone have never ceded, lost, nor forgotten their responsibilities as the caretakers of this place, as well as for all peoples who reside in their traditional territory. As guests, we recognize that we benefit from living and working on their traditional homeland. We wish to pay our respects by acknowledging the ancestors, elders, and relatives of the Ramaytush Ohlone community and by affirming their sovereign rights as First Peoples.
Thank you very much. Okay, so Diana, you're gonna do the roll call?
Yes, next slide. Okay. Per the IWG bylaws, the IWG must vote to excuse any absent members. If the working group does not take such a vote at the meeting or at a previous meeting, then the minutes shall note that the absence.
If I can't, I'm afraid to turn off my camera.
Any member who
Steve,
misses,
excuse me, Ms. Member Fields, you are unmuted. Could you, thank you, yeah.
so any member who misses 3 regular meetings within 12 months without the express approval of the IWG at or before each missed meeting will be deemed to have resigned from the IWG 10 days after the third approved absence. So nobody has submitted a request for an excused absence, and I actually think all of you are here, but I will call roll. And if you are here, can you please say here or yes or present or something like that? Member Fields. We see you. Wait, we're gonna unmute you. Member Fields, are you here? He's here.
Yeah, yes, I am. Can you hear me?
Thank you. Member Gonzalez. Here. Member Hammer.
Here.
Member Lipton.
Here.
Member McGuigan.
Here.
Member Patterson.
Here.
Member Salinas. Here. Member Short. Here. Vice Chair Short, or, you know, your honorary, whatever. Member Wong.
Yeah, Your Highness.
Yes, your Highness. We have 9 yeses and 0 no's, so we have everybody is here. We deferred the vote last time to excuse member Patterson, so I think we should like to do that now, but checking with you, Sarah, if we could do that vote now.
Sure.
Okay, so this is to excuse member Patterson, who had a death in the family last time, and last time we deferred it because we didn't know what the deal was. So now we're going to go around and I'm asking you to vote yes means to excuse and no means to not excuse. Is that clear? Because that's a little bit confusing. Everybody get what we're voting on? Okay. Member Fields, we're going to unmute.
Yeah, can you hear me?
Yes. Okay, thank you. Member Gonzalez.
Yes.
Member Hammer.
Yes.
Member Lipton.
Yes.
Member McGuigan. Member Patterson.
Yes.
Member Salinas.
Yes.
Member Short.
No.
Member Long.
Yes.
Okay, we have 9 yeses and 0 nos, and so member Patterson, we're having excused absence for what month is this? That was August. And I pass it back to you, honorary member Short.
So we're at meeting goals?
Yes.
Okay. So the meeting goals today are about update on bed optimization, update about community engagement, and then our report from Dr. Cummins. Then continue discussion of our draft resolutions, discuss the IWG progress report, and then report back on the meeting structure discussion, which was fun. And today we have the following, I see what's going on. Okay, so that's what we have there. And now look at our domains again. The people that are presenting are going to be Carla Beek from the Controller's Office, for the bed optimization. Oh, but she can't make it. So Eric Rodriguez will be the,
Who's waiting? Who's up there?
oh, okay. Hi, Eric. An interesting title, the Principal Bed Flow Analyst. And then Deborah O from Interethnica and Ashley Vaughn from DPH Communications. We'll talk about our community engagement plans. We have Dr. Cunnins, of course, for the director part, and that's it for our special guests. So we got to approve the meeting minutes. I don't have instructions on that, so do we have,
So they were posted to the website. So does everybody have them or has everybody had a chance to read them? I think is the first question.
yes, I mean, I think we should be prepared to approve or not right now, so. Do we do a round?
Did you want to do your good governance thing now or? Okay.
I'm sorry.
No, it's me tripping on my
Oh,
own.
maybe. Then I'm-
Excuse me, my stupid thoughts. So, in response to discussion last time, I did circle back to, oh, no. The city's gonna, but that start, I know I feel that way about it.
Don't step on the members.
You're good, you're good. No, he hates feet.
Okay.
Anyway.
Not everybody's a fan.
Oh.
So, I can pass this around and we can post it on the website. Basically, I just consulted the Good Governance Guide to make sure that we, are following guidance for minutes. It unfortunately depends on which kind of body we are deemed to be, and I'm waiting for feedback from the city attorney about what that is. But if you read through the options in the city's Good Governance Guide, it appears we have some flexibility about how our minutes are recorded. So I think a lot of it comes back to the discussion that we've had last time, is what would be of most use to the members and your preferences. And so I'm happy to just hand this around and let folks take a look. I think it's just up to you whether more discussion is needed to decide what type of minutes, whether we want to keep with the kind of minutes that we currently keep or make new changes. And of course, I will update you when I get a response from city attorney's office about what kind of body we are deemed to be for these purposes. So
We refresh me, was there a particular problem identified with the
Yep.
method of minutes? Okay.
I'm adverse to having minutes that record what everybody says.
Okay.
It's, you know,
You wanted to have more
in the minute, it's supposed to be focused on what was presented.
Yep.
And that there was discussion and then the vote, and not to have what every member says as part of the discussion. That's,
Okay.
I think that was the issue.
So it sounds like we don't exactly have an answer, or?
Because we don't know what kind of group we are.
Right.
Okay, as deemed by the.
That's sui generis? I don't know, maybe.
Okay, so sounds like you're still working on that, and we'll have to come back to it.
Okay.
But thank you for doing that.
Valerie, so you say that, the minute's gonna have to reflect based on what kind of group we are. I thought we've been established that we are a consultation group to the DPH for the IWG implementation.
you are, there's different kinds of advisory groups in the Good Governance. So
Uh-huh.
need a little bit further legal direction. We're considered to be, so what they, type of advisory body they decide that we go.
Oh,
Yeah.
we know what kind of group we are, but they have a technical
Yeah,
category
it might be helpful if you.
that we would have to be
So,
into.
sorry, there's no answer yet. I'm just waiting to.
Okay, but thank you for,
So that's a question about the minutes though. Is there, and Jen, this may be a question for you, or maybe you understood this from your preliminary conversation. Ari, is it, if we all agree that we don't, that the more detailed minutes are not needed and that it's taking a lot of staff time, And actually for each of us, like for me to review the minutes, takes a lot more time than I'm used to, because I want to make sure that it's as accurate as possible, especially what I said. What, but we could just say, like, that's not required in any of the different kinds of advisory bodies, right?
No,
That kind of
that level of detail is not going to be required by any of the what.
Right, so
what
maybe
we
just
put-
this, yeah.
Yeah, and so these are going to outline the baseline. what we need. Okay, but it seems.
Lorraine, can you stand closer to the microphone?
Oh dear. It seems that we are exceeding the baseline amount.
No matter what kind we are, right? So could we just say, could one of us make a motion in the approval of the minutes this time to make a motion to simplify the minutes?
I think you could, I would maybe suggest deferring until next time when we have a defined answer of
Okay.
what the baseline requirements are going to be, but it's up to you.
Do you think we could have a commitment to get that answer prior to the next meeting so that we
Yeah.
can make that change that motion?
Yeah, I actually
Okay.
asked quite a while ago. They have changed our state attorney contact, so it's just a little.
Well, we could just pick up this red phone and.
I know.
It's so tempting. Okay, thank you. Okay, so now we're on to discussion item 1. Which is approving the minutes. So are there any changes that anybody has proposed? I'm deferring to Valerie, we already did that. And then let's open up public comment on anything related to the August 2023 meeting minutes.
Okay, so members of the public who wish to provide public comment on this agenda item, which is discussion item 1, approving the August meeting minutes, are invited to participate in 3 ways. First, I'll call on anybody who is here in person. Then we will call on the people who are joining online, either by phone or video. If you're joining by phone or video, please raise your hand and we will unmute you when it is your turn to speak. By phone, you press pound and then pound again, and then *3 to raise your hand. You will have 2 minutes to speak when it is your turn, and we'll give you a 30-second warning when your time is nearing completion. So is there anybody in person who would like to comment on the minutes? Not seeing anybody in person. I'm looking at the meeting attendees. And nobody has their hand raised. So I think we can close public comment on the August meeting minutes.
Okay, thank you. So now we get to approve the minutes. Do I have a motion to approve the minutes? Anyone? Okay, is there a second?
Second.
Okay. All those in favor? No, you do
I do a roll
Sorry,
call
roll call.
thing. Well, member Field, so yes, saying yes means you approve the minutes. Member
Yeah.
Field. Okay,
Yeah.
thank you. Member Gonzalez.
Yes.
Member Hammer.
Yes.
Member Lipton.
Yes.
Member McGuigan.
Yes.
Member Patterson.
Yes.
Member Salinas.
Yes.
Member Short.
Yes.
Member Wong. We have 9 yeses and 0 nos, so we have a majority vote to approve the August meeting minutes. Back to you, Chair.
You're 5 minutes ahead.
great.
You're making the trip
I don't-
right on time.
I don't want to be too successful. Yeah. Put it in for permanent. Okay, so discussion item number 2 is the bed optimization. Eric Rodriguez with his fancy title. Eric, you're filling in for Carla, so welcome and go for it.
All right.
Oh, yeah.
Can get the slides up, or
Can
Thank
you
you.
make it a lot louder, I think?
can everybody hear me okay?
Oh, better.
Mhm.
Yeah, sure.
All right. Okay, so hi everyone. My name is Eric Rodriguez, and as we mentioned earlier, I am the principal bed flow analyst at MHSF within BHS. And I'm here to update the IWG on the status of the patient flow and bed optimization project. Thanks for everyone's time here today. Before we begin, I do want to give a quick shout out to Carla Beek with the Controller's Office. She and I have been working very closely together on this project. She was initially going to lead this discussion, but unfortunately she is unable to be here today because she's dealing with a family issue. I know she was looking forward to seeing some of our different collaborators and stakeholders, and she sends her regards. So I'm going to do my best to fill in. And so just to give like a framework of the presentation, today we're going to give you updates on just like the general project overview, what's been done so far, the scope of the project, the time frame of our data, how the model functions, improvements from the previous model, and our next steps. Next slide, please. So some background. In 2020, we created a bed model and analyzed patient data to help guide patient flow improvement work. And so this time around, we have a couple goals coming from that previous project. Firstly, we just want to like update that work from last time, still using the same vendor, MHSF. Our second goal is to improve the like underlying data structure that supports this project. So that way BHS can independently and regularly repeat this work. So that means tracking bed utilization and identifying needs so we can optimize patient flow across the system of care. This will also allow DPH to study the impacts that bed expansion investments have on client wait times. As I mentioned earlier, the Controller's Office has been instrumental in advancing this project, and their scope specifically is to collect and analyze data to support MHSF's work, perform cost analysis to determine gross and net costs of bed expansion proposals, and to support the development of DPH's final report and presentations that are going to come after the model's analysis. Next slide, please. So this slide shows all of the work that's been done since the initial kickoff in March 2022. Much of it centers on gathering information and data, which the vendor MHSF needs to actually run the model. But a nice benefit of that work is that it'll also aid future DPH efforts to improve just general data collection related to patient flow. So that analysis work we can kind of put into two buckets. Qualitatively, which is that those purple lines there. We've held interviews with over 40 subject matter experts, which we're also calling SMEs or SMEs, from both DPH and also select community-based organizations. And those interviews helped us determine the project scope and methodology. And on the quantitative side, so the teal color, we've also done, as I mentioned, the financial analysis. We've also collected, cleaned, and analyzed encounter data that's going into the model. We've also worked with our SMEs to compare the initial model results to their real-world experiences. And finally, we've relayed any of the feedback from those subject matter experts to our vendor MHSF so that they can make any necessary adjustments to what the model is doing in order to better match the SME observations. Outside of analysis work, we've also been soliciting and executing the contract with MHSF. And lastly, about 3 months ago, BHS hired a new analyst to lead the ongoing bed flow efforts after this version of the report is completed, and that's me. Next slide, please. So what is the scope of the MHSF bed modeling project? On the left side of this slide, the chart shows the 10 categories of care that are included in our analysis. So that's emergency services, acute care, post-acute care, crisis stabilization, locked residential treatment, voluntary residential treatment, low threshold care facilities, therapeutic residents, transitional and permanent supportive housing, and residential care facilities. And then that second column shows you examples of what each of those categories are by site. And so just some notes on the bed included, or the beds included. The current optimization analysis includes several types of new beds, which were not present in the previous version of this project in the last analysis. Those include transitional and supportive housing, our post-acute care like Laguna Honda, Chinese SNF, and ZSF G4A, and medical acute and emergency care. Also, just a note that some sites were excluded in this go around due to things like data availability issues. being considered outside of scope, and not being, either they were sites that were not yet open when we started the project, or they weren't open long enough for us to be able to pull a good amount of data from them to be able to do this analysis. Next slide, please. Thank you. So the time frame of the model, by which I mean the time frame of the data that we are using in the model. So the previous bed optimization analysis completed in 2020 used data from fiscal year 2018-2019. And as our previous slide showed, slide 3, data collection for the current project began in October 2022. At which time we had to choose between using either calendar year 2021 or fiscal year 21-22. And so in our analysis, we concluded that calendar year, or in our initial discussions, we concluded that calendar year 2021 provided the most recent reliable data for multiple reasons, mainly or including the relative stability as far as like COVID-19 cases. Omicron spiked or began to creep up and spike in December 2021, and then peaked in January 2022. There were also multiple ambulatory care sites which switched electronic health record systems in January 2022, and then they were unable to combine data across two systems. So we basically had to choose between a larger amount of data from the legacy system or a limited time frame of data from the new system. So for those reasons and more, we decided to go with calendar year 2021 in our data that we're using. Next slide, please. All right. So the final output of the simulation model is going to be the number of beds required at each model category to eliminate wait times for 95% of clients at each of those subcategories / sites. So one thing to call out is that moving forward, DPH is going to have the ability to test out various additional scenarios using that same modeling software, which we're getting from the contractor. This is going to let DPH study the impact to the system from changes in bed counts, lengths of stay, or admission rates. So down at the bottom of this slide, or middle bottom of this slide, we have a little diagram of how the information flows into and out of the model. So that first square, the model inputs, basically we provide data and information around bed counts, admission rates, and lengths of stay to our contractor. That information then goes into the model, which uses it to simulate thousands of encounters in each category and determine outputs, including a bed occupancy rate, which we're going to be calling utilization in the paper, as well as wait times for patients in the model in cases where utilization hits 100%. And in our model, in our paper, rather, we're going to be calling that queue durations. And then finally, for all subcategories with simulated wait times, the model is going to run over and over again, increasing bed capacity each time until there are no wait times. And then, of course, at each of these steps, we've been meeting with SMEs to help validate our model inputs and outputs and just check what our model is showing and what we're telling to our contractor against what the SMEs know to be true in their day-to-day work. Next slide, please. So what improvements have been made since our last report in 2020? The majority of the improvement work for this version of the analysis has been to the information provided from our side, the DPH side, as far as like the data going into the model that I just mentioned. So that's arrival rates, length of stay, and bed counts. So I guess to break that down, we increased the scope of the project by adding categories of care. And this is providing a more holistic view of the entire system that we're modeling this time around. We also increased the scale and quality of the data that we collected. So we're pulling longer timeframes of data, which is leading to more accurate lengths of stay calculations. We are doing more thorough data cleaning, which is improving the way that we're calculating admission rates And both of those combined is helping us rely less on an optional adjustment factor that the model has built in. And that adjustment factor is basically to make up for discrepancies between the simulation and real world observations. But we're seeing fewer of those discrepancies, so we're relying less on that adjustment factor, which is good. It's proving that the model is simulating the real world reasonably accurately. And finally, we added demographic information and developed a patient matching methodology to track individuals across different data sets, which were coming from different sites and different either DPH programs or community-based programs. So what do these changes add up to? What does this do? The patient matching system that I just mentioned created a unique patient level data set of current demographic utilization across the system of care. That allows for a more detailed analysis of the input data and just a very valuable, and I think to my knowledge, first time we've had a data set that's really matching people across so many different programs that we're able to see how folks move through these programs as far as the input data goes. This also is going to provide a more accurate information on admission rates and lengths of stay, and that's going to improve the modeling to provide more accurate utilization and those output wait times that we were talking about earlier on the previous slide. So what is not included in this version of the model include like movements between categories of care as far as the model is going to simulate. So each category is a distinct system in the simulation. Although, as I mentioned before, we do have that input data. So like, I guess the input data being actual encounter summaries versus the model, which is using that encounter summary to simulate patients over and over again. So in the model, it's each system or each site and category is just a distinct system. The model also will not tell us if individuals are in the most appropriate level of care or what that level of care would be in an ideal situation. And the model is not going to tell us if increasing beds is the right or the best solution. So the model is just going to say how many beds do we want to reduce wait times or to eliminate wait times. But for example, while the model might say to increase beds at an acute care site to reduce wait times, in real world operations, it might be more appropriate to add downstream beds to a post-acute site in order to reduce lengths of stay at the first location and open up beds that way. All right, next slide, please. So what comes next? Our next steps are to continue working with MHSF just to run the model and get their analysis and output. After that, we're going to write up and present our findings to stakeholders. And then in the, I guess, middle term goals, DPH is going to develop tools to routinely model additional scenarios, assess capacity and patient flow, and identify any data needs. So these additional scenarios may include things like increasing the number of beds at specific sites or reducing lengths of stay, and just trying to analyze how changes in patient care or changes in our system are going to impact overall patient flow. And then finally, the conservator's office will scope out the next phase of project support. So what does that next phase look like? The conservator's office is going to scope this out, but certain things that we've discussed as potential future projects include data entry and data pull improvements to reduce the number of files to combine and the amount of data cleaning that is required just on the input side. We've also talked about more comprehensive inclusion of housing data, which folks have been very clear that that is a priority to include in any next iterations of this work. Also thought about assessing the impact of diverted or unseen clients that don't make it into the admission data, which is what we're using to model our patient flow. Also systems to measure whether clients are in the appropriate level of care, which I mentioned earlier is not currently in the model. Also, we've talked about an analysis of readmission rates at specific sites or categories. But I also want to open up the floor to the IWG and see what other projects or analyses that y'all are interested in. And I can just go to the next slide here at that point. So if anybody has any questions about what I've just talked about here, or has any recommendations or requests as far as future work, now's your time. Thank you.
It's like Steve has the first hand up. Can you hear us?
Thank you.
Steve? Okay, good.
Yeah. Thanks, Eric, for the report. As one of the SMEs, a whole new title, I'm going to work it into my resume somehow. We had a chance, along with others, to sit down and actually unpack the work that you've reported today and discuss it. And it was a uniquely useful exercise to be in a discussion where both you and Carla were seeking context as much as numbers, and because context is everything in this system. And so it's a great report, and a 1,000% improvement on the previous version, which was driven by some narrow concerns. I want to raise a couple of things that we raised in our discussion when Progress Foundation met with you, and just reiterate a couple of the important future plans for this. I think the problem many systems of care have is that they assume because a person is targeted in a certain category, say inpatient, for skilled nursing services, that if there's a backlog, we need more skilled nursing services, which is the danger of any system. And I think what's important about this report is it highlights the need going forward to try and look at the whole issue of what's the most appropriate level of care for people that we need. And, you know, as a agency that's provided alternatives to skilled nursing, it's always been frustrating that is that getting into the hospital to say this person may have been put on a list for skilled nursing when they first entered 3 weeks ago, but they've improved a lot. What's your model inside the hospital for looking for an alternative? And that gets back to an issue that'll have to drive this all along: is what is the direction of treatment that CBHS is heading in? Is it trying to maximize effective community-based treatment, or is it just looking for the most convenient bed to put somebody in to take the census down wherever we are, and to improve bed optimization? So I'm really looking forward to the next phase of this, because the groundwork this data lays is one that the system has to discuss, which is right at the core of what mental health SF is about. What does the community-based system need to look like to provide alternatives to incarceration, alternatives to involuntary treatment, if we're going to be serving our clients and the residents best? So I want to congratulate you and Carl on this. It's a really strong report. Look forward to working with you in the future.
Thank you, Steve. Likewise, good to see you. And yeah, as I hope I stressed enough, this work I've been very reliant on all the work that Carla did before I got here 3 months ago. But it's been nice to come into this environment where people are already having those discussions, and I look forward to continuing to have them with everyone.
Emil. Member Patterson, sorry.
Oh, I don't have much to say, but the report is a couple of things just concern me, just with the whole notion of like, you know, when you were talking about beds, getting people in and getting people out, it made me look up the statistics for all of the homeless in San Francisco. So the concerns that I just have is just I mean, I know, you know, you got to get people into beds and stuff, but you got to be more than just getting people in and getting people out. You know, I worked in the shelter system. I know some people, it actually helped them more to have a longer stay. than others, so, I think like those type of things that, there's that small part that just, comes to mind when I hear the report. And so I hope those things come into account because, a person isn't just a number. Some people do need a shorter stay and get in another person. But some people might need a longer stay because they got some things going on in their life. They're actually, progressing and things. So, that's pretty, that's pretty much all I got to say. It kind of felt a certain kind of way, get one in, get one out, and are we kind of just holding the homeless situation in place? So I land the plane here.
Yeah, thank you, Member Patterson. That is a great comment, and a very important perspective that we do want to keep in mind. Like when you're doing any analysis, I like to approach it from the perspective that we are, at least as far as the input data goes, we are talking about real people, and that's why one of the things that we want to bring to the model that unfortunately aren't in this iteration is that I think you were kind of talking about like the making sure that people are at the appropriate levels of care. So we don't necessarily just want to reduce lengths of stay across the board. We want to just make sure that we have the capacity to care for people at the most appropriate level of care. And when I say most appropriate level of care, you are absolutely right that some people do need to be places for longer for different reasons, and that could be in a shelter environment or in a hospital environment. But we just want to make sure that when people are at, for example, like an acute level of care at the hospital, that is, and one thing that we're going to bring to the model using outside information in the SME conversations. Is to make sure that when people are at a location or a category that feels like where they're supposed to be. So if someone's in the hospital, it's because they're supposed to be in the hospital. What we are hoping to alleviate is currently there are oftentimes where people are at a more acute level of care when they would be better served by either a skilled nursing facility or a shelter bed or some other subacute treatment, things like that. But yeah, we definitely don't want to just be trying to like churn people through the system, but how do we provide appropriate care at different stages in someone's, I guess, like cycle of need to make sure that they are getting the care that they do need. Thank you for your comment. I appreciate it.
Thank you.
Member McWigan and then.
Yeah, thanks. Kind of one of my biggest gripes since I've been on here, the thing that I've been trying to stress is that I'm a big believer in, whatever gets measured gets managed. And I don't think that the data collection points are great from my experience, but just so this is just input data from the bed sites for the bed modeling. Is that it? And who is doing the data? Who is inputting the data that you're pulling? And where's that data from? I don't know if I missed that. So where's this data speaking from?
Yeah.
So the data.
So this analysis is covering 40 or so different actual sites, or I guess what we're calling model categories. So there was those 10 categories I mentioned earlier, and each of those is broken into multiple model categories, and some model categories are specific sites, like Laguna Honda North or Laguna Honda South, and then some model categories are composed of multiple sites. But so we have basically broken it down into like 40 different model categories, and each of those categories provided their data as far as client encounters from different time periods, with us focusing on calendar year 2021. Yeah, so it is a good question as far as like how do we judge the quality of the input data. And when I say input data, that is things like what we're mainly looking at from all of our different DPH sites, as well as community-based organizations. We're mostly looking at who arrived when and when did they leave. So we're able to use that data to basically build a bucket of the different lengths of stay and see what that distribution of different lengths of stay looks like at each category. And then using that, the model is pulling that information along with the capacity at each model category to try and determine what is our utilization or overutilization. Are we operating over capacity at different places?
Is that a requirement for each of these sites to have to input? I mean, like, you know, in my one site visit, they weren't doing any of that data collection or anything. I don't mean to be a pessimist. I don't see that the numbers and the people that are doing this, because I've asked a million questions about Epic, and you know, I know that we don't want to stick nonprofits into, you know, and services into saying you have to use this, but I just don't. I'm just wondering, like, how many data collection points are there? We're looking at 50. Is this a required for each of these, you know, 10 different categories that you say, and then are broken down into 40 categories? I just think there's a lot of redundancies, especially with those 40 categories that could be more efficient. And I just, the data collection and the numbers is kind of what drives me in this group. And I want to get a better understanding. I don't want to beat this to death, but I just, you know, if you can give me kind of just, hey, you know, out of all these places, they are required to, or they're not. Are you looking at, you know, we have 5 from this place, 100 from this place? I mean, you can kind of make numbers look whatever, but I'm just wondering, is it required that they have to do the data input and get information to you? And if it is, what mechanism are they using? Are they using all different? Is somebody sending you a Word document and you're compiling it? Is it something through Epic? Is it just whatever? I mean, if you can give like a brief minute overview so we understand where the data input's coming from.
Yeah, so that's a great point. If we weren't able to get accurate data from a specific site, we couldn't use it. Basically, like, we don't want to bring in inaccurate numbers to the model, because that's, you know, it's not going to give us a useful output. So we did do that determination, and that is why we chose to exclude certain sites. Check my notes here. Because of the lack of data that was available. So things that we didn't have access to were historical BHC residential care facilities and residential care for elderly facilities. We could not include Odyssey and Broderick for that same reason, as well as state hospitals, just because we couldn't get data from them. Obviously, we would like to include those sites, but it just wasn't possible at this iteration. And then there were also sites that, if they were only open for a short period of time, it's hard to look at, say, several months of data and then determine, oh, this is what your large scale, long time frame arrival rate looks like. And so when you were talking about places that are required or aren't required to track data, that was basically a major limiting factor in getting that historical BHC residential care facility, residential care for the elderly facility data, is that they, to my knowledge, their requirements are a little bit looser than most places. And so they were only able to give us like a daily or like a single day census. Thank you. A single day census. So we worked with them to try and come up with an arrival rate that made sense, and doing an estimate of the people that we can't see in a single day snapshot, like how many people are we missing here. And that's also going to be a big part of my a big part of my work after this report comes out. So as we mentioned, my title is the Principal Bedflow Analyst. And so I'm going to be focusing on not only like what we need to put into this model, but also what are we missing that we aren't getting from sites? Like, what sites are not able to get us good data or quality data? You talked about information going into Epic, which has been great and transforming a lot of the data that's available at different sites or categories. And again, not everybody uses Epic yet. But the second phase of that, after like what information goes into the electronic health record system, is really pulling the information out of the electronic health record system in a way that is legible and actually useful. So before I was here, I was at ZSFG for 3 years, where I had a lot of experience dealing with Epic data and the variability of that data and the variability in the quality of that data. But yeah, you definitely bring up important points to consider whenever doing any analysis, is just making sure that we can combine data across different sites. And unfortunately, this version of the report, there were places that we wanted to include that we couldn't just because the data wasn't there. But we hope to make some progress in the next year or so before the next iteration of this, working with those sites to make sure that they are tracking things in a consistent way and accurately as well. Does that kind of get at your question?
Yes,
Enough for now.
enough for now, yeah.
And sorry, you can also please email me as well, eric.rodriguez@sfdph.org.
I think it's on the question part, you have your email, right?
Yeah.
Yeah.
Yeah, okay. Maybe I'll follow up with you so we don't waste everybody else's time. Sorry.
Thank you.
It's a great question, because, yeah, so.
Go ahead.
Yeah, as I was just, I guess this relates to, because I was gonna ask what the data cleaning means. Is this what you're explaining about the data cleaning? Does that, sparsing out who has not collected reliable data? Is that what you mean by data cleaning?
That is part of the data cleaning. Also, so yeah, I guess to get hopefully not too technical, to where I'm losing everybody, but when we were pulling data from different places, we are kind of reliant on the quality of the data that they keep, and also different organizations are tracking data in different ways, and some are in Epic and some are not. So some of the files that they gave us, we're not, basically what we wanted to put into the model is patient A arrived on this date and they left on this date. Patient B arrived on this date and they left on that date. But that's not what we were able to get. We weren't able to get data in that format from every place. I think a good example would be a lot of the long-term care facilities were kind of grouped together. So our RCFEs, our RCFs, and I think it was PsychSNF. They were tracking data not by individual patient, but by fiscal year. And so they gave us a file with, I think, 5 different tabs covering fiscal years, 2017, 2018 into 21, 22, I think, if I'm doing that math right. And so across each of those tabs, it basically had a yearly census of who was here during this fiscal year. And so if someone was there for 5 years or 10 years, they were showing up 5 times across that data. So what we did and what we worked with the contractor to do on their side is to identify all the patients that are present multiple times across the data that we were getting from those sites, which was a little bit more challenging than we would have liked it to be. For example, someone on one file might be Steve so-and-so, and on another file they're like Steve and so-and-so. So trying to see what information can we combine across these different tabs in order to make sure that everyone's only counted one time, or every encounter only counts one time. Because if you're counting someone multiple times, it's going to throw off your length of stay distribution. So that was one example of some data cleaning. Another bit of data cleaning that we had to do was the information that we got from ZSFG was very detailed, to the point of perhaps it was definitely a conversation of like, is this too much information? Because we were defining encounters in a slightly different way than a lot of ZSFG analysis does, because a lot of ZSFG analysis is when does someone arrive at the hospital, when does someone leave the hospital, and we're kind of looking at when does someone arrive at a specific type of bed and when do they leave a specific type of bed. And so they were able to give us basically times when anyone changed a bed at all, but someone might go from one bed in med surg to another bed in med surg. And so it was conversations about like, well, when do we want to split what happens, what this person experienced in the hospital into different encounters for our model. And that required some back and forth and some conversation with our subject matter experts at ZSFG in order to get that data to a place where we're accurately measuring what we're intending to measure.
Continue.
So again, going back to the data collection, I think there's different systems through Epic, different systems through Avatar, but nothing, lots of folks that probably aren't really doing good about using Avatar. And so we'll all be on Epic, right, this spring. And so I'm wondering, I understand that folks are currently in phases of just figuring out how to create the interfaces for the outpatient providers, right? For Epic, I think figuring out these things for data collection. I mean, in the past, I know definitely at least the ICMs and the FSP used to have some monthly reporting on certain measures, which we all complained about, and we're very happy when we didn't have to do those reporting on different measures like incarcerations, hospitalizations. But if there's a way that could be easily captured in Epic, that would be great, or little things that we could easily click. That would be great. But I just want to, I think that it would be really, really important as soon as, I guess you're developing a model that hopefully you will be able to run and rerun successfully. And that you would do that as soon as possible once we're all up on Epic. And also because the conditions have changed dramatically from 2021 to 2023. And we're looking at, I'm on almost weekly case conferences with the inpatient team because of my folks there. And they're looking at that they have had the lowest number of discharges ever in the history of San Francisco General on the inpatient unit. Like July was the lowest number of discharges. There's absolutely 0 inpatient beds, right? So moving through. So we're having folks that can't get onto the unit and folks that are needing to get off the unit without any place, really a feasible place, a rational place really that matches their level of care to be discharged from the unit. I think that our patients are getting more and more acute. And if we're not having, say, I have a client for instance, at Door this week. When I was there on Friday, there was only 6 people total in Door. And I don't think that's, so they had a lot of empty beds, but I think it's because folks are too acute to even go there, right? So this is the issue. Like we're having folks, like she went to Duck 3 times before she got there, right? And had to be turned, kind of kicked out one time, turned away because she needed a hospitalization, and she never got actually to PS, but she spent several days in the ED to get stable enough to then go back to Duck and then make it to Door, right? So we've had, say, someone on the inpatient for weeks now because she's not stable enough to go to the dual diagnosis. So folks aren't able to get there because they're not getting the stabilization. So if we're looking at empty beds, some way to track qualitative data as well, like what happens, like why doesn't this person then get from, say, PDS or the ED to where they need to go, and that either in the inpatient or in the community because of just lack of appropriate levels of care for what they need to get stable enough to get to the next steps, right? And then it becomes harder and harder to get, you know, somebody who probably would have, you know, done well with a 2-week hospitalization and then been able to go to a dual diagnosis now is needing 4 to 6 weeks in the hospital because of disease progression, because they never got and so the level of care they needed to begin with. And then this is costing us so much money. So I guess just trying to figure out how we can implement some qualitative data collection and not just quantitative data collection to tell the story of why this is. Why is this person cycling? If you're seeing this person multiple times coming and touching different places, why is that? And then I guess just a clarifying question at the end is like, with the next steps, you were saying the conservator is going to scope the next phase of the project, or is it the controller? You were saying the conservator's office. Is the conservator's office really going to do that?
No, that's the controller's office. Thank you. I misspoke.
Okay.
I appreciate that.
Okay. But I guess that's it. I mean, so I just think that I'm not sure that, yeah, you know, I'd hate to have this be garbage in, garbage out. So if we can report, you know, redo once we actually have the data that we need, and if we can accompany some of this with a lot of qualitative to understand why someone is touching all over the place so many times. But it's great that you're able to capture that, and it's like having the same, it sounds like you'll be able to capture individuals that are all over the place, which is very useful. Thanks.
Thank you.
Member Wong, did you have your?
I just wanted to comment, and it may be a little bit off track, but it's on the same track. It's just about the data. I think James brought up a really good point about the accuracy of the data collection. And you mentioned that you weren't able to get data from selective sources. And you mentioned a couple of times BHC, Merck, RCFE. And I'm just kind of surprised that data are not available because there are flows in that building and in those programs, particularly the Merck, the BHC. I'm just kind of, you know, I think along the line of the accuracy of the data. In order to get the accuracy of the data, then you can actually kind of mirror or at least modeling some of the models, whatever that you guys are trying to do. So that's just comment, and I think data collection is important, but the accuracy is even just as important. So.
Thank you. I'm gonna move it along to Member Lipton.
Thank you. I'm surrounded by people who know far more than I do. So please bear with me. My understanding of what you're doing is really looking at bed utilization, not bed optimization. Because you're not really determining whether people are in the optimal level of care. And so therefore, it's really bed utilization. So I just want to start with that because I think it seems like it's a little bit of a misnomer to call it optimization. The second, and I also truly understand that you got to pick a starting point. And I understand the reasons you picked 2021 as a starting point, calendar year 2021. I think from the perspective of mental health SF, this is a dynamic, or is supposed to be a dynamic program to create several hundred new beds. And I'm not sure how many, I forget the number of beds that have been created.
400?
300-400,
Yeah.
you know, and over the last couple of years. And I think we just have to understand that though the use of those beds, I guess, are not included in the study. And we're not going to be able to derive information from the study as to whether those beds are actually in the categories that would best serve what would be mental health SF individuals. And so I think it's a very valuable study that you're doing, but I also think we're leaving some things on the table that would be very helpful to kind of know how we're doing qualitatively in the implementation of mental health SF. That's all I want to say.
I have Dr. Hammer, and I'm gonna put myself in the back after that. Is there anybody else for this item? Okay, member Dr. Hammer, Dr. Member Hammer.
All right, so Eric, thanks so much for your, I think you guys have done an amazing job trying to collect information and I really appreciate your presentation as well and responsiveness. So I have a few questions. So Member Wong mentioned the places that you were not able to get data. And can you clarify, because I'm a little confused about slide 14. Which lists examples of of where you did collect data. And I see most of the programs in the BHC listed there. So I thought I understood you to say you did collect information from the BHC, including the RCSP, but that you weren't able to get data from all the RCFPs in the city, so that's a limitation. But can you clarify that?
Yeah, thank you. That's a good question. So we were able to get actually we were able to get a lot of data from the non-BHC RCFs and RCFEs. That data did require some cleaning that I talked about earlier. So what we weren't able to get from the BHC sites was historical data. They were only able to provide us with a single day census, and that census did have people who were there. Some of them for like 5-7 years, so people who were there for a long time. And what we then did is compared that single day census from the BHC sites to the non-BHC sites and the non-BHC sites over time, where we did have that historical data, to try and say, like, this is who is here in BHC on this day, or at the BHC on this day. Who have we missed that was here over the last year? And so what we weren't able to get from BHC is specifically that historical data is what we couldn't access, or we didn't have access to. And so that is information we have to supplement with conversations with our subject matter experts at the BHC.
Okay. And then for Laguna Honda, I'm also a little confused. Again, what's included in that slide 14? Because it looks like excluded is post-acute care at Laguna Honda, but then I see that other Laguna Honda programs that you are including those. Is that correct?
So that I think you're talking about on the right side where it's so the beds included. When I say the post-acute care at Laguna Honda, that is included in this version of the analysis, but it wasn't. We did not include that in the previous 2020 version. So that first three grouping, the transitional supportive housing, post-acute care, and medical acute and emergency care, those are included in this version of the analysis.
Those are included. Okay. And then I just want to make a comment about Member Lipton's comment about utilization optimization. So my understanding is that this analysis, which is about bed utilization and our understanding access and flow to residential treatment beds, that is what should drive what we've sort of hung our hat on, dating back to the previous analysis, the previous report, what we're going to hang our hat on in order to optimize bed capacity in all the different categories of care. So utilization does include, like, our people, our beds being used and to what extent, so to help drive an understanding of capacity, and then gaps, like where we need more beds. That's how we got the 400 beds, the 413 or whatever beds that were originally included in the mental health SF legislation. So am I correct in that what we hope to get out of this is a new target for what, when you look at it now, what we're gonna need in terms of new beds.
Yeah, yeah, that is correct. And I guess to also, uh, I guess maybe clarify a little bit of what the model is. So there's kind of there's information that we're getting from the model, and then there's information that we're getting from conversations with our subject matter experts. And so we are you are correct that the model is going to show us what utilization it looks like, and you're also correct that we're going to then use that utilization information to drive conversations about optimization rather.
Yeah.
And so the model is going to give us a piece of that conversation, which is our utilization numbers, but then we have to then talk with people. Like the model is only going to show us so much information, and there's a lot of real world experience that we also want to leverage when we're making our report and then our final recommendations for what beds do we need where to optimize flow.
I have a question and a comment, and then Member Lipton for me. My question is, and I think people are kind of getting to this too, is about use of the data. And once we have all of this information, are there any stated uses for how this is going to inform policy, or who receives it, and any discussion or sort of obligation for it to be used in any particular manner, or has that been determined anywhere? And I guess my point being, I'd very much like to see this make a difference in terms of we are, the right people are going to get their hands on this data and make changes accordingly, so that we literally don't have the wait times, and that people do get immediate access to the beds. So start there, and then I have a comment after that.
Yeah, so we do have additional projects in the pipeline that we're kind of determining where to go from here, and that's, I think, part of that controller's office scope conversation, because you're right that we have put together a very uniquely valuable data set here of who is using what beds and for how long, and we've also brought in demographic information to that. So in the report currently, we are going to have a little bit of a demographic utilization aspect to it. But honestly, that there's so much to talk about there, as far as what barriers to care are there for different groups of people in the city. That it's definitely something that we don't want to just limit to this report, but also be able to use that data moving forward to explore additional things. And yeah, you're right that we absolutely want this to be impactful and to actually lead to changes and more equitable outcomes for people throughout the city and things like that. But so we're still scoping out what specific projects we're going to do with that data.
Thanks. So I think that if we get data out of this showing that we have far, less beds than we need to actually meet the need, then it would actually be irresponsible to not act upon that data and make the changes and improvements that are necessary to rectify that. And so I would say, since it doesn't seem like there's any necessary I'll use the word flow, from required from the report to a decision-making body, or to use it to make those changes, that I suggest to my colleagues that that be something that this group continues to work on and to take a look at that data and make sure it's moving us, towards addressing the situation, right? It seems very appropriate for that to be this body, at least one of the ways that we can maybe move it along. And then the second thing I was just going to say was, and I think you were kind of hitting upon this, Member Salinas, is that, and this is no criticism of your report, because this report is what it is. It's about beds. It's about that resource of the bed. But we all know at this point that beds are not enough, that staffing is critical, and that we can have all the beds in the world and they go unutilized. And they do right now in the city, even though there are plenty of people with the need because of staffing issues. So I just want to make sure as a body that we're very attentive to that, that if we over focus on beds without also addressing the issues of staffing, which is recruitment, retention, quality work, working conditions, et cetera, then we're not actually meeting people's needs, because they won't be able to use those beds. So I know Member Lipton has a question. Is anybody else after that? I assume we should wrap up.
In interest of time, I pass.
Are you sure? Okay. Yeah.
So in the first bed optimization report, I was noting that it did say that the analysis was not able to calculate true demand, that is people who attempted to receive services but were unsuccessful in doing so. And I guess just coming back to in the examples of potential future work, if that might be something to include it, because you did ask what other analysis would we be interested in. I think that would be very useful to see who is attempting to access services, if there was a way to capture that with the data, and what happened that prevented that, what barriers we can, and this. It's a sentence in there. You'll find it. It would be great, I think, if we could capture that in future analysis.
Yeah, definitely. We absolutely agree. And so I guess capturing that full demand involves a conversation of how are we defining full demand. And one thing that we're strongly looking at is looking at referrals to specific sites, and then the rate of referrals actually leading to admissions. And so there's some variability at different programs between how much they're actually tracking those referrals or how they're tracking those referrals. And that's something that I'm going to be working towards in the future to standardize. But yes, thank you.
Thank you. And I really want to thank you, Eric, for being here, especially when you're pinch-hitting. So appreciate that. I know we need to move to public comment.
Yes, and I also want to point out the clock in the bottom left is not correct for I don't know what reason. It's like 10 minutes behind. So if anybody's relying on that clock in the bottom left, don't do that. Yes, so public comment for discussion item 2, bed optimization, is now open, and you are invited to participate in one of 3 ways, either joining in person, or joining on WebEx via calling in or on video. If you are on the WebEx, if you can and want to publicly comment, please raise your hand and we will unmute you when it is your turn to speak. If you are joining by phone, please press star and then star again, and then, pound and then pound again, and then star 3 to actually raise your hand. Everybody will have 2 minutes to speak, and I will give you a 30-second warning when your time is nearing completion. So is there anybody in person who would like to do public comments? If you can speak into, there's 2 of these pod things, if you could speak into one of the pods, and then the people on WebEx can hear. Thank you.
I just have one really quick comment, and that is, maybe if we knew exactly who the stakeholders were, I see stakeholders mentioned a lot, we might be able to get a little more cohesion in who these projects are aimed at and who they're helping. Thank you.
We can't really respond to the comment. Yeah.
He's here with the.
Yeah.
Oh.
And anybody online, I don't see any hands raised. I think we can close public comment.
Okay, so we're going back to the report on community engagement. And this is the discussion group report back. So I'm passing it to Valerie and Ashley. So, yeah, I will see you, Valerie. Switch.
Hi all. Advance the slide, sure. So I actually think that, and Ashley, you're online, if you can unmute yourself. I think you were gonna handle this.
Yeah, so I can go ahead and get us started. And for those of you who don't know me, I'm Ashley Vaughn. I'm the communications manager for behavioral health services. And I've been here a few times to present to IWG on mapping. And so we'll kick this off by grounding in what mapping means. We're actually working on several different mapping requests. And some of those include how do people find a service, and updating our service directory, MHSF program specific service landscape, our optimal service flow, which we'll be focusing on today, the actual client flow across the continuum, which is what I've been working on, accessibility mapping, so how clients access services, and then what's our service capacity? How many programs do we have? How many clinic sites do we have? What does that landscape look like for the organization and the system? Can we go to the next slide, please? And so, as I mentioned on the last slide, we are focusing, or the IWG and this group is focusing on optimal service flow across our range of services. We do have a lot of different requests that we're filtering or funneling or working on. For example, we're working on redesigning our website, adding information on our services, our providers. That is currently in the works. We recently launched a new substance use and overdose landing page where you can find treatment services along with training resources and information on how to get access to those services. There's also service capacity, so the bed optimization survey. And then there's accessibility to mapping, the actual client flow, which is our Office of Coordinated Care, and then our residential care and treatment or expansion of that through MHSF. So again, we're focusing on a very narrow view, which is the optimal service flow. We do have our actual client flow, but what we want to hear is more about how clients are accessing and experiencing our services. Next slide. And Valerie, feel free to jump in anywhere. And I believe I'm actually.
You know that I'm very comfortable interrupting.
Yeah, so I think this is Jen, right?
Yeah, yeah. So hi, everyone. So just as a reminder of where we are kind of in the facilitative process of doing this optimal service flow. So we have the IWG recommendation, which was done by a discussion group back in February, and they identified developing 3 maps of what ideal service flow would be. And then at that time, we discussed the opportunity to engage community to explore a little bit more of like the ideal to the actual. So after February, DPH took that in-house. So that's what Ashley has been working on, is developing these initial maps of ideal flow for community engagement, talking to people within DPH, identifying and kind of laying out what that ideal flow would be. And now we're at the point of community engagement. And so now Interethnica, and Deborah O is here with us from Interethnica. She's up there on the bar with all of us that are joining remotely. She and her team are coming on to really help us think through how to develop and implement this community engagement process. And that's thinking about these ideal flows, what community experience is, and from all of that, there'll be an opportunity then to refine that optimal service flow and use that community feedback to understand and consider improvements. So there's 4 steps that we've gone through. We've gone through the first 2. We're now at step 3, and then we will move on to step 4 after community engagement. Can you move to the next slide, please? And I think the important thing is, one important thing to note is like while we are focused on this optimal service flow of the continuum, and we're going to learn a lot about the actual client flow, the community engagement around optimal flow will probably give quite a bit of information for all the other mapping things that are going on. So that's why there's an orange circle of community engagement that runs through all of these mapping, but the orange circle around optimal flow is kind of where we are really focused in on for this particular community engagement. So the questions will be focused on that, but they may inform other mapping efforts that are underway across DPH. I'm going to pause here. So Ashley or
I want,
yeah.
if you could back up, I just wanted to add to it that I think something that maybe didn't come out super clearly in the discussion group is that part of the feedback we got from Deborah as a subject matter expert in community engagement was just to make sure that we seize the opportunity to make sure we're not closing ourselves off to feedback and community engagement from the kinds of questions we're asking. And so I think we want to try to structure the questions we're asking community engagement broadly enough that we make sure that we would hear feedback that we otherwise might miss. So while we want to get feedback on the maps, we want to allow some room to sort of hear more from the folks who are participating, which I think will help inform some of these other efforts as well. So.
Yeah. Thanks, Valerie. Yeah, so and when we talk about community, because community engagement, who is the community? Who are we talking about? That's a really important point. Who we are talking about is 2 populations, and they are both related to the specific mental health San Francisco population that's identified in the legislation. So whether you're a provider or a consumer, you have to be in some way connected to adult San Franciscan residents with serious mental illness and or substance abuse disorders who are homeless, uninsured, or enrolled in Medi-Cal or Healthy San Francisco. That's the legislative priority population. So when we thought about the 2 groups, one is the providers that serve that population. And so Ashley and folks within DPH have been doing a lot of talking internally to develop these maps. What we want to do now is engage the community of providers who have not been part of this conversation to get their feedback. So that's one community, is a community of providers that serve those who are part of the MHSF priority population. And of course, the other part of community is those who actually access services, so consumers of services. And those would be, again, the priority population of the legislation and what their experience is with DPH services. Next slide, please. Thank you. So, we want to ensure that we're asking, questions of community engagement, as Valerie said, that are specific enough to be able to get this information that we need for the maps, and broad enough to be able to inform other things, and that we haven't closed ourselves off. So when you think about what the goal is an effort to better understand how clients and providers experience the behavioral health system of care, and specific to the mental health service San Francisco population. And it will help us inform consumer access of care, consumer flow through the system, and how providers connect and refer clients to care. And with that, I invite Deborah to the conversation because this is kind of the point that we've taken it up to. And as Valerie mentioned, Deborah's been a really helpful thought partner in building out what this could be and being really responsive to what the needs are. So thank you, Deborah.
Thanks, Jen. Hi, everyone. I'm Deborah O with Interethnica, the community engagement consultant. So keep in mind that this is one of the first opportunities for community engagement. So it won't be fully comprehensive of everything we want to learn, but a starting point to start engaging with the public and get some valuable input. So I'll provide a logistical overview of how we envision the community engagement process. So like Jen mentioned, the first group is providers. So we will conduct one virtual listening session with providers. And then the other group is for consumers or clients. And since this group is a little bit more difficult to reach, we plan to meet them where they are. So instead of expecting a large group to show up all at the same time and place, we'll conduct this listening session in like a roadshow format. So that means we're showing up to their preferred location using their preferred method of communication, whether that's in person, on the phone, or virtual, and keeping these groups really small or one-on-one, given the discussion around personal experiences. And then for recruitment, we'll develop the recruitment material, including screeners and posters and flyers, and calling recruits to confirm their participation. And the screener helps ensure that we recruit a diversity of participants, looking at demographic factors like age, gender, race, length of time living in San Francisco, as well as the types of services that have been utilized and their access point. Next slide, please. So this is the discussion guides will be tailored to each group. And so just to provide an overview of the flow of the listening sessions, we would start with intros and a brief background, and then we would start with a focus on personal experiences. So for providers, looking at what their past and present experiences navigating the system of care is like. So it's learning what their process is when clients come to them to access care, when they through different access points, whether they walk in, a phone call, emergency room, and then the step-by-step process that they go through next, whether it's handing it off to a clinician or the referral process, and then diving into the specifics of their lived experience. For clients, it's similarly their own personal experience of how they first sought behavioral health services, and then learning about what types of services they were looking for and received and how this process was overall for them. And then diving into identifying the gaps. So what parts of their experiences worked well, what didn't work so well, and what were some challenges they faced. Once we identify those gaps, looking at envisioning an ideal pathway. So how could this process be improved? And getting really specific on what an ideal path of service would look like. And then to close, to leave it open to participants to share anything that they didn't have a chance to share. And so based on the feedback we heard from the IWG discussion group we just had, we'll adapt the proposed flow and questions, particularly for the provider group, to get a little bit more specific around the areas of feedback we are looking for. But I will pass it on to the IWG members who participated in the discussion group to go over some of the feedback they had.
As a reminder, that was members McQuiggan, Salinas, and Moore. May or may not remember being part of that group at before.
Going on Monday. Yeah. Yeah, it was kind of a quick call where, we were just kind of going over, some of the, how they wanted to attack this. This is a little bit of the summary of, how they wanted to talk to both providers and consumers. My only question was, and I think you were there, and it was brought up here, it wasn't on your slide, but I guess a question I had, you mentioned, wanted to measure I guess one of the questions was, how long has somebody lived in San Francisco? And I guess my question is, what is that qualifier of living in San Francisco? If they say, because I know we kind of disagree on this one, but how long has somebody been in San Francisco? because I think this is kind of getting into, I brought this up in our call, in our discussion group, that I feel it's getting into more of a federal and state issues, because I don't think that, in my experience as a firefighter, working with people and responding on the street, that many of them are from San Francisco. And my qualifier, when I use that, it can be different from everybody else's. Did you go to high school here or go to college here? Did you grow up here? And I just think that we're kind of almost building a services that many people are coming here to use. And I think we should be getting some federal and state funding, because we're taking care of more people that are not from San Francisco. So my question would be on that question for you. How do you guys, what would be your qualifier if somebody lived in San Francisco, or how long have they?
And I can talk your scale, because I was part of that group, and Deborah, definitely feel free to jump in, or Jen. I think the way we were thinking about it too is talking about their experience with care, and where have they got care before, and that kind of thing. Is obviously, if they're at this point, something didn't work at some point, and so trying to figure that out and going about it from like a history of care rather than necessarily a history of residence. And we could talk about, as Deborah said, we're gonna have some screening things, we could talk about it there. But as far as like the information we want to get from people, like where have they gotten care in the past, whether that's somewhere else or whether that's here, and what has that looked like?
I think that probably you and I also, while we have a lot of overlap, you also are seeing a population that's probably much newer to San Francisco than, of course, the high end, because folks, if they're at ICMs, they have been here in the system for a while for them to get to ICM. So, and I bet that if we're reaching out to consumers, we're more likely to end up reaching people that have been here for a while, right? Because they're in some way reachable and organized, and or somehow have a support to get to
They have people helping them keep on track.
Yeah, they have need getting them in a lift to a meeting, right? So so we aren't going to capture those.
Somebody that's going to be in the Bay Area, that's got their family or friends that are still here, encouraging them, yourself, your group. But obviously, I say that because you're going to have greater success when you're the people that are going to push you into these programs or help you, when you're down and people need support. And that support group, works best when you have family or friends that are around,
And folks will have been if they're coming to the consumer feedback, they have been getting some services here for a while, with which to report on, versus folks that are maybe newer to San Francisco and on the street and haven't been. Right, so it's a different probably group that we'll end up reaching here. I did want to just say, like I do welcome in trying to capture information outside of what we are mapping for providers. I think just in being thoughtful about that, though, nonetheless, it's useful information, but being thoughtful then, what are we going to do with that? And I think that I recall some years ago going to a focus group for ICMs and FSPs, and there were staff from all the ICMs and IFSPs. And in the end, we felt really, this person that had been contracted, I think they were from Boston. And then we saw what came out of it. It was like absolutely nothing that we said. We were like, this was nothing that we brought as our concerns to this focus group is reflected in what is being like. It was like, I and Charlie Berman, who I'm sure you guys know, we went and we're like, what? This is like, we had so many things that we're like, yes, they're going to listen to us. And we brought all this stuff and absolutely none of it was reflected in what came out. It was kind of Twilight Zone-y. So I want to, even if, we are taking into account that information, what are we going to do with it? Because then people also have an expectation that you're going to what's going to be done with it. And so that there should be actionable steps then beyond the mapping, then if we're going to also listen to all this information, because then people get very frustrated. So that is my concern about like, what's the promise for them? Because if we're not really, it's useful information, but if we're not doing anything with it, people get frustrated. I think also, again, I think just with like the ordering, I do have lots of things, but this might not be the ordering of the questions for the consumers, but you can't start with an open-ended question. It's just a list, but it'll be structured differently, because then if there was somebody like, it's had to.
This isn't the only time, Deborah, it's gonna be here, like, we're imagining this is a standing item for the next couple of meetings, while, but exactly your point, members, is that, like, you all can see different versions of the protocol let's talk about. That's a really good point.
Diana, we can hear you, but you're pretty quiet. So please be sure to speak forward into the microphone. Deborah, did you hear that?
I just want to,
Excuse me, wait, before we move on, Deborah, did you hear that full comment?
No, I didn't fully hear that last comment.
Okay, could you repeat that, please?
Yeah, I just said, in response to member Salinas wanting to make sure that like the protocol was, like in an order that makes sense, and that this group thinks a lot about what happens to the results, that Deborah, this isn't the only meeting that you're gonna come to, that we imagine that you're gonna come to the next couple, and probably have some other discussion groups too, to get that kind of input.
And Steve, I see your hand raised.
Oh, yeah.
oh, the others, you see Steve Field? Okay, I did not.
Member Field, sorry. Just want to make sure I'm highly attuned because I'm also virtual.
Yeah, thank you. I was, two questions, or one question, one suggestion. The community engagement on the provider side, it's unclear what the modality is and the context for that meeting. Is it an intention to invite certain groups to that as representative across the provider community, or is it open-ended for anybody to attend who feels they have something to say about this? And is it really designed to be like one hour? There's a lot of information out there that's going to have to be organized and fielded. So first of all, what's the context of the engagement with providers? And then my second comment is, appreciate the work that the IWG folks did, but we just spent close to 2 hours on a discussion about bed optimization, and unless you include 24-hour care in the outpatient category, which there's a very specific reference to intensive case management, so I suspect it's not meant to be a catch-all. There ought to be a group that looks at the 24-hour care system, because we understand that's where there's going to be a lot of consumer feelings about what happened. And it certainly gets at, from a provider's point of view, the changes in the relationship to the hospital's priorities compared to 5 years ago. So I believe there should also be a group of providers that come from the system of 24-hour care and housing as a specific experience in the system. They're not covered by just outpatient or intensive case management. So first of all, what's the context of the meeting? Is it 1 hour of invited folks? Is it an open forum? What are you thinking of on that?
Okay, Deborah, did you want to respond? And then
And my question was actually just tagging on to that. Also, this looks like just mental health, and I'm wondering whether it will include substance use services as well.
So, do you mind putting it back to the people?
Right now, it's just me.
It's worse from when you had it.
I don't remember.
Please, we can't hear you. Please speak up.
No, it's internal, don't worry about it. Yeah, there you go.
It's internal. Don't worry about it. Okay.
We just wanted to make sure we could see you.
She's far away from the microphone. She's actually talking pretty loud.
Okay, so we just want to see, Deborah, did you want to respond to that and also what?
Yeah, I can get started.
your average is?
Our
Yeah.
we envisioned the listening session to be about like a 1.5, 1.5 hour session. And since the providers have already been involved in the development of the mapping, we were looking to talk to specifically those providers who haven't been involved in the discussion. So who are completely unaware of the mapping process, and leaving it open to whoever is interested in attending the listening session. And we were looking specifically at providers who serve MHSF priority populations. And what that is, that's kind of where that's the type of information that I'm here to understand from the group here.
Thank you.
Yeah,
Member
I'm
Patterson?
sorry, just to follow up though. So then what will be the methodology of informing the provider community about when and where and how the listening session is going to happen to make sure you capture those people who you haven't talked to yet?
Yeah, so for the recruitment process, we are still narrowing that process out. So my understanding is that we are going to work with DPH to do the provider recruitment. So that could look like reaching out to the contacts that they already have via email or phone calls, posting flyers and posters in different clinics and areas that the providers are at.
Thank you.
Yeah, and Steve, just a follow up is like the provider group is like discussion group is coming back together to talk a little bit more about it, just because like we're already considering like we were going to do like kind of one kind of provider group, and now we're talking about splitting it into two. That'll influence the whole outreach strategy. So there's still some work that is in discussion that's happening.
And that's also the process of the screener. So we reach out to a wide variety of providers, the public, and then the screener is used to. So like if providers who have already been involved in the process sign up, then those are the people who wouldn't be invited to the focus group since they don't qualify, since they already have provided their input in the past.
Okay, thank you. I know Member Patterson's had his hand up, so.
And for those that's been with me on this, I mean, I haven't been, to the meeting in a long time or to the panel, but people know I've been saying, man, we need mapping. We need mapping. I've been saying that for a while. And I don't know if you covered it. I mean, I was taking notes, but, you get a little dreary in these meetings. I think, San Francisco has been dealing with the homeless situation for since the 70s, so there's a lot of extensive programs already in the system. So, I mean, I will start with like looking at what do we have all together. And I say that from working in the homeless field and from being a client, The other part is, this is a mental health panel, right? So I think there needs to be some defining, or redefining, right? Because automatically we talk about, you feel me? Automatically we talk about homeless. We talk about, and this is mental health. So, there's already, we keep determined that certain things kind of are associated, the mental health. And then I know from my training in the homeless field, if you're homeless for 6 months to a year, it's already defined as a mental health. So all of these things, as far as mapping it out, yeah, they all kind of need to be joined officially. Sometimes I don't know, is mental health and homelessness, or is it joined, or are we just kind of So we definitely need to determine that. You know, whether it's, you know, you got health, mental health, homelessness, and if there's something else that's associated, have all of these fields together, maybe there should be a big website for services all together. And then I also think, I don't quite agree with looking at whether somebody's, I mean, I do agree with it in funding, as far as, remember McGuigan brought up, but I don't agree with it, with looking at if somebody's a San Francisco native, for services, you know, as a medium for who gets services or who doesn't. Because, you know, this is what you should look at. This is what you should look at. It's a mental health issue, and it's also an economic issue. So some people are going to be homeless. They don't want no responsibility. That's just what it is. I know people like that. I know people whose, you know, family members, you know, they own land, and I want you to come over, but they want to run the mission. And this is where they get their groove on there, right? You know, it's little things, you know, in the homeless field about people having keys and stuff. Some people don't want keys. They don't want the responsibility of keys, right? So we need to, so I say that to say, instead of whether determining if somebody's from the city, we need to determine if they have this mental health condition and this is where they're at, or somebody that's trying to move along and that's trying to move up and have an apartment and have a job and contribute. And I think, so we need a ladder system. And that could be a native person or somebody coming in here from Texas. I know somebody from Texas came in and moved on up and they wanted to get farther in life, right? People come to San Francisco for a lot of different reasons. The services, some come to get rich and wind up becoming homeless. So I think in the mapping out, and then another thing too, is I always get more of a ladder or more of a clearer picture from clients when along the system. They tell you this, that, and the third. I went here, you know, and more so than the counselor. And then shelter providers have met in the past. I don't know if they're continuing to meet. That's, you know, maybe that's some of the problem. And then some of their meetings that I went to, they're not, most of them, they're not really intentional. It becomes a meeting of jockeying for funding. Where it needs to be, you know, like you have to change the system. I don't know how much that's in effect, but, you know, it was useful because, you know, there's service providers from everywhere to put notes. So we may be dealing with the same client. This client is caused havoc at 5 shelters. That's going to be in the changing system, right? So I just think, you know, we need to get back to that, you know, to that aspect of it. And when it comes to people meeting and things like that. And you never know. I mean, even people that stay at SROs and stuff like that are still kind of closely related. So, you know, I don't know. I'm just trying to give you a view from the ant. You know, the ant can't see what the eagle sees, but the eagle can't hear what the ant hears. And I'm the ant. I'm so I land the plane there.
Thank you. I wanted to ask in relation to that, so I heard that the discussion group will be meeting again. When is that, if that's planned, and can you know, new people join that if somebody, say, advertised or anybody wanted to part of that? Is there an opportunity for that, or?
Yeah, it's not scheduled yet, and
Okay.
I think the facilitation team is happy to like hold again additional participants.
Okay, yeah, let's just say if you have a particular interest in being part of that.
Yeah.
That second,
Can I get a clarification? I'm looking at it says providers, is it contracted by DPH? Is that the only provider focus that you guys gonna have? Or?
well, they're the only ones providing
For the mental health.
services that we're asking about. So I think I'm just sorry, I'm jumping there. So it makes sense to me that that's who the providers.
Yeah, I will say that part of the framing that we've given to Deborah is that, is to try to stay within the MHSF scope. So we want to try to keep questions and participants sort of aligned with MHSF key populations. And then in terms of providers, I think we may do some outreach to the Office of Coordinated Care. We do need to take a look at the system that we are actually able to impact. So the feedback, it reflects what we can actually, and this is being done in part on behalf of the IWG as well. So that's also to inform you in your advisory capacity about where there are gaps in the MHS system.
Thanks. So, and I didn't want to piggyback on Member Patterson. I mean, I think I got the same sentiment. If we have existing providers, why can't we just kind of go back to the providers? I understand we have that year that, we've been looking at, I think, previous presentation. I mean, I think a lot of the situation have changed, community has changed, the whole entire city has changed. So I think we really need to just kind of really reflect on what's happening now. And yeah, I'm just kind of concerned that, we're not kind of capturing what is existing right now. I mean, I think I've said that in our meeting group, and I just want to piggyback on that. And I just feel that the existing is what people know, who people engage, who's connected. So yeah, just want.
I want to add one piece just to be clear about the scope. There's sort of a limited amount of budget to do these sessions to start with. It's a complicated funding mechanism in the city, but it gets accrued as a percentage of over time. And so I want to take all this feedback and we want to, part of what we need to continue to discuss is what we actually have capacity to do. We can't do probably more than 2 sessions the first time around, but I'd love to make sure that we can make the best use of those. And then if we need to hold on to like next phases of what engagement would look like, be able to try to use like future budget as it accrues toward this to explore more questions. So I'm disappointed that it's limited as well, but I want to be clear about capacity here. So.
Okay, is there any more comment or questions before we're gonna?
Just because Jen, can you hear me?
Yes.
I'm going to assume because as Jamil said, I am loud. Yeah, so we'll get, in the interest of, because there's obviously a lot of interest, we'll send a doodle in our after meeting communication if you would like to be part of the discussion group that continues to talk about things like who is invited, how they're invited, the questions that they're asked, those kinds of things. Then encourage you to respond to that doodle poll when we send it out.
Okay, let's go to public comment.
Thank you. So members of the public who wish to make a public comment on discussion item 3, which is community engagement, you could do that either in person or by raising your hand on the video. If you're calling into the WebEx, please press pound and then pound again and *3 to raise your hand. Each person will have 2 minutes to speak, and I'll give you a warning when your time is about to be up. I do not know if you need to be human to speak or not. So is there anybody joining in person who would like to publicly comment? Okay, I'm gonna open the attendees list to see if anybody is raising their hand. I do not see any attendees from the public who are raising their hands. Give it a second. I think we do not have anybody who would like to publicly comment, so I think we can close public comments. Passing it back to the chair.
Thank you. So we get our,
Let's take a 5-minute break.
yeah, let's do that.
Are we gonna, since we're already at the 11:05 mark, are we gonna get 20 minutes from Dr. Kunitz, or is that gonna be pushed, or is that gonna be truncated?
She has a little more.
It's a little more time for those of you on. Yes.
Thank you.
And if you need to use anything in the building, there's a tag here.
And it's 11:04, so I'm gonna cheat a little and say get back here by 11:10.
I'm actually.
We're all gonna go.
I thought she was gonna say.
Oh, okay.
Thank you.
Oh, I know.
All right, I'm gonna put out.
There's a kitchen that I found, but I.
What do you need?
I was gonna get a cup of coffee, I'm gonna run fast. Yeah.
Yeah, so like 3 doors down. is
Yeah,
the
okay.
coffee place.
It might be 11, 12.
Do you want,
Oh, I
to
better get a cup of
Phil, make
coffee
sure you
then.
can get back in the
Oh,
building?
that'd be a good idea. So much. Anybody else want a coffee or anything? I'm going.
I had sweets. Oh, you're beautiful. Baklava.
No, we're gonna all be on a sugar high.
I know. Kaylee, how is it being in person?
Want me to give you one right now, Steve?
Is this?
Work.
We're hit hard and fast. But I'm pretty sure things will not be so cautious and next time.
It's curious, I don't know, like, which countries, I know they use age. It's freaking out. No, hey, please.
But now it's like a total.
Adding, I think shirking my responsibility already.
I don't.
Yeah.
It is.
I saw, I wonder if anybody's taking.
Buddy.
No.
It's 11:14. I'm already shirking my responsibilities as chair here, so let's
Oh, look at you. You're 5 minutes
crack
late.
the whip. Okay. I believe we have enough people, right?
Yes, we have a party session.
Without further ado, then, let's get back. I think that we need to make sure we're recording before we start. Is that correct?
It's recording, yes, we did.
Oh, we are, we didn't stop. You heard all of our side conversations.
We muted.
Oh, okay, good. Really glad to hear that. Okay, so I'm gonna hand it over to Dr. Cummings for her report. Thanks for being here.
Thank you for having me. Good morning, everyone. I'm sorry I missed the earlier conversations. I got a little updated, but I know there's some pressing issues. We have our one of several annual state audits in play right now as we speak. Something called the EQRO, which is the state coming to audit, it's in this case, our substance use related services under the Medi-Cal program. And so that is a multi-day audit that is happening for, I think, 3 days as we speak. So I was just at the opening session, just as general information. We also are audited on the mental health side. These are two separate auditing processes for the moment. And that will happen later this fall. So I have some remarks. I want to share a couple of updates. And then also just discuss recent news coverage of about a building under consideration for the Mental Health Service Center, which I know came to news attention. So first off, we have a couple of hearings in front of the Board of Supervisors this week, including one on overdose, and that is in front of the Public Safety and Neighborhood Service Committee. This meets Thursday at 10 a.m. Two things will happen there. One is there's a piece of legislation requiring retail pharmacy naloxone, which we supported. We're very happy to see move forward. The other hearing is on the accidental overdose death report, which you all have heard about here. The Office of the Chief Medical Examiner would be the primary presenter, but we will be providing an update on overdose in the city as well. For those of you who have interest, I encourage you to tune in. We also have a hearing this Friday, September 29th, in front of the Homelessness and Behavioral Health Select Committee on the Care Court launch. As you, I think, all know, Care Court is due to launch, I think it's actually October 2nd, because that's the Monday. So Dr. Gonzalez has been meeting with Dr. Almeida, both of whom know our planning team, getting us ready to participate in that. The governor, just FYI, was on 60 Minutes discussing Care Court sometime in the last couple of days, if that's something that also interests the group. Finally, and importantly, we have a hearing at the end of October to provide an overview of the behavioral health system of care in front of the Board of Supervisors. I just want to acknowledge your collective I would say nudging, if that's a technical term, and sort of encouraging all of us to be clearer and more precise and sharper about the way we both think about, present our services, including, I know, some of our mapping work that is overdue, but nonetheless, this kind of has really, we've been trying to move forward. So we are very busy. That's also just in summary. I want to just talk about the building that came to news attention, and I'm sure, and heard from Valerie that this was understandably not okay with IWG. I just want to kind of acknowledge that. This has been, so I wanted to describe where things are at and sort of how and why it came to public attention in a way that we were unprepared for. This is a building I think we had mentioned probably a year ago to this group, that we were aware of a building that we were looking at. And I would say that that is still the current state of play. We are looking at this building. We have been in a conversation for some time around a variety of things, including compliance with seismic requirements, the need for assessment of the safety of the building, which has been a back and forth and obviously serious practice. We have not shared this information with this group without naming the building or the specific building, because it's been standard practice for the city to not discuss real estate negotiations while they're underway around price and sort of demands that the city might be placing on building renovations and construction. And so we did not anticipate it coming up. It did sort of a planning context. Yes.
Shy Bar will continue to be there.
So we have.
To the initial point.
So all of that, and I am not also in the middle of this, that is all part of what is getting negotiated with the current owner and with the city, with our real estate department. I did want to tell you and hear from you directly about what our intent is with the building, and also to say that it is not finalized. So the building itself is 7 stories plus a ground floor. The intent would be, again, still being planned, is that 5 of the 7 floors would be for consolidated office space for behavioral health staff. We currently mostly sit at 1380 Howard, which you know and love, as well as some other offices and buildings. The first 2 floors would be dedicated to client services. It's proposed that the services would include relocation of nearby the Behavioral Health Access Center, or BHAC, our office-based buprenorphine induction center, or OBIC, and the Behavioral Health Services Pharmacy, and a medical laboratory, all from their current location at 1380 Howard. The space,
They would all be brought into this building. Okay.
they would all be brought into this building. This, if you've been in the BHAC, if you've been at 1380 Howard, and if you've not actually taken a tour, and I'm actually realizing, I'm not sure we've ever done that, we would be delighted to walk you around 1380 Howard. And in addition to the lovely conference room, to see how the services are organized. They're quite split up, and it's not really ideal for the delivery of clinical services. Should funding be available, also the first and second floor do have space to add services if that becomes possible. So if the city moves forward and is able to reach agreeable negotiations with the seller, there will be a robust public process, including coming back with additional opportunity to the IWG around recommendations, I would say in particular for design of the service-oriented space. So it is very much an opportunity for us, but it is by no means, but it is in negotiation. I think that was not totally clear from the public press. And I am sorry, we were also taken off guard by it coming out and did feel premature. It's been quite protracted because of building negotiations. So it really, this is a building that we mentioned, that I mentioned to you probably almost a year ago.
Kind of, that's a quick question.
No, that's all I have. That's like formally prepared. So you're the chair short. You can.
I'll answer that question and others, of course. Well, first, I just want to remind everybody that a mental health service center was always, part of mental health SF. So that's not a surprise. And I'm actually glad to know we're moving forward on that. I mean, I am a fan of the chai bar, so I was, but the other part of what I was going to ask, I'm just curious, like, has your comms team done any attempt with the Chronicle or whoever to try and correct that message or counter it, get a new, release out there or something to get them to, because I've seen a lot of hoopla about it, where, another technical term, where people are making a lot out of it. And if it's not at all true at this point, that's really a problem. And I know it's hard when something's out in the news, really hard to redo it. But anyway, I'm just curious though, if there is a burden. I sort of feel like, those damn reporters should be held accountable kind of thing. So.
So yes, we've been trying to spread the facts as I've just described them to you, which is it's in negotiation, and further that it is going to involve about 300 staff members who will have their administrative space there, which will bring about 300 city workers into that corridor. As city workers who might be buying lunch, for example, shopping at IKEA, and so forth. I think additionally, it is intended to be a welcoming clinical service and not a drop-in space where people would stay for all day or overnight. For example, it is much briefer, intended to be similar to what we have at 1380 Howard, briefer interactions with folks coming in for a specific, finding out about a service, receiving a referral or placement to service, getting a specific medical encounter or medications. And so we've been aiming to share that information. We have been involved with speaking to a town hall that Supervisor Dorsey organized. We will certainly be meeting with others. It remains, I would just say, complex because it's still being negotiated, and the market has likely changed since we first looked at the building, and that is among the things that is being deliberated.
Where's the building at?
So it's, the address is 1190 Market. 1090 Market.
Alchemy.
It is right on it's right near or next to Urban Alchemy, Home Rise, right? That's an office there.
AIDS Foundation, you know where that is? Yeah.
So between 6 and 7.
Yes.
Yeah. So other questions to remember for her full report, not just on the building here. Member Salinas.
What's the date of you said that I tuned in when you said the subject matter of the hearing, but not on the date of the hearing there was an overview of the mental health system of care?
Not till later, October 27th.
October 27th.
So in essentially in a month.
The new homelessness and behavioral, yeah.
With the new, and just for, I think everybody knows, there's a committee entitled Homelessness and Behavioral Health Select Committee. It's a select committee, so it'll be in front of that committee.
And I guess just on the issue, I didn't read that article, but that's an excellent location, you know, Citywide needs to be on that. Well, where IKEA is now, so right on Market Street for the first 30 plus years of our existence, or not, no, for many years we were there on Market Street where the old Social Security building used to be. We used to be right over Social Security. And it was a great spot, so accessible, right? And for citywide folks, that location for BHS services would be hugely convenient. Actually, no, not anymore, because we're going to be moving next to CAP. But if it were where we are now, because we go to OBIC, we take our clients to OBIC and to TAP, and it would be so convenient. But now we're equidistant to old 1380, December 1st, and that spot, but still it's super convenient for folks on Market Street to just walk right in there. It's a great spot for that to be located. Much better than where all the services are now.
It's fine.
Great, yeah.
Others, again, about the full report, anything to do with the report?
Probably the insight piece that was in the paper the other day.
I couldn't see what you.
It's the full nonprofit science.
Oh, yeah, sorry. Yeah.
I flagged this to Valerie,
Yes.
I guess it was yesterday, just to make sure that, I wanted to make sure you had seen it.
Thank you.
And I don't have an agenda with this. It's just that one of the things that the IWG, I think, really needs to do more of is doing a evaluation of how programs covered by mental health SF are working. I suspect that the department already has a battery of programs that you use to try to evaluate using the terms of the column, process, outcome, and equity. But I think for a future meeting, we ought to have a more expanded discussion of kind of what those are and how they're working, and how this body might be able to look at that and evaluate it and make recommendations.
Yeah, thank you for that. And I concur that evaluating what we do is paramount importance. But I think the article, let me just offer just a few comments additionally. And I think it'd be great to describe where we do and don't have evaluation. Oh, and Valerie is idiot proofing me. We've actually been separate and aside from this article, really trying to enumerate what we do evaluate routinely. I just mentioned the state audit this morning a little bit purposefully. Steve, knowing getting the heads up from Valerie, we are audited under Medi-Cal by the state for things like timeliness to service, retention in SUD treatment, frequency of use of medications for SUD, which we know are evidence-based. Similarly, readmissions to psychiatric inpatient care, medications for mental health, so on and so forth. So I think so for our Medi-Cal reimbursed services, we are audited actually in 3 separate audits: our EQRO audit, our managed care plan audit, evaluating us as a payer, and then a annual Department of Healthcare Services audit. I would just offer, sadly, unfortunately, they're not all looking at the same thing, which is, I think, fair. The programs are different. We are in a relatively constant state of finishing audits and preparing for audits. I think, and sometimes the forest gets lost through the trees. We have a lot of accounting for sort of the widgets, and maybe what gets lost is sort of the highest impact metrics, some of which we do measure routinely, and we should sort of say that and share that. Where I think we have less potentially robust audit systems is in some of our non-Medi-Cal services. One attempt to redress that, for example, is the SOMA RISE evaluation, which you all know about, which is underway and which we want to share once ready. I think to Steve's question, thinking about that as a group would be very helpful, and thinking about it also in practical terms where we do, I want to share how much work goes into our auditing. I want to understand what feels available and accessible publicly, and then do a better job of communicate that and figure out where we can put effort to fill in gaps. But I don't think, I just want to offer, I don't think that person who authored that opinion piece really knows enough to be, I think he was a bit overconfident in what he was saying. And so I just kind of wanted him, he's a resident physician at UCSF.
Oh, okay.
Let me see that after too.
Curious. Okay.
I was just gonna say, I have been on the other side from like years long ago when I worked for the California legislature for about 5 or 6 years, that the closer you were to a news story, the more the story probably didn't tell the whole story. So, it's just a way of reading articles and not taking them all as fully accurate or not fully accurate. And I appreciate your comments. I just wanted to.
Thank you. I appreciate it.
What I want to do is put on the table, because I think it's something that we just need to do and need to put on the agenda for the IWG. And maybe because part of our recommendations, or we're going to talk later about the annual implementation report.
Yeah, and I will say that I totally understand Dr. Cunnins, especially dealing with the press myself, and how they just want to get a scoop and stuff gets out there when it shouldn't. I understand all of that. I will just say that once it got out there and there were news reports about all of this, that would have been a good time to back to us and say, hey, I want to make sure y'all know here's the real story, especially because we want to be reinforcing, we want to be helpful in reinforcing the truth. And also don't want people to be asking us about it and being on guard and being like, we don't know what's going on. So thanks.
Yes, totally. And I want to just say for any of you, I totally appreciate that feedback. Chair Short, and if any of you are finding that we're like, hey, we need you to email us, we are really happy to. So happy also, we all get in our own heads and bubbles. Very much appreciate, please. I think I want to know what's going on if any of you want to email us, but I feel like we should, please, can you send a note to the IWG? And happy to do that, to be reminded of that.
Thank you. And then can you say a little more about care courts? You said Governor Newsom was on 60 Minutes. I know that now is the time for implementation. You might not have time to say everything we're doing for that, but I am curious, what are we, what does that mean? What are we doing? And if there's not enough time, how can we find out more about the details of that?
Let me say a couple of things. I might ask Annie to chime in. The team, so the care court is a court program, meaning the court, and it's been set up in San Francisco under problem solving or collaborative court system. So the courts are being set up to hear petitions. And I'll say a word about that in a moment. For people who might be eligible for their situation or case to be addressed through the mechanism of the care court. Eligible people are people with a psychotic disorder or schizophrenia spectrum disorder with psychosis. It is not, and so that is that is a specific group of people and does not include, for example, people who might be experiencing psychosis due to methamphetamine use. It is intended for people who are not stable in care and for whom this is a potentially less restrictive opportunity to be engaged in healthcare than other more restrictive things like conservatorship, like assisted outpatient treatment. Additionally, it does not have the force, there are no punitive elements of it. Meaning if somebody doesn't adhere to what has been described in the legislation as a care plan, there isn't a legal, civil, or otherwise consequence to that. So it is very much an engagement-oriented approach with the idea, at least this is the hypothesis, that like somebody might go before a judge and it's sort of the weightiness of being in a court and having a judge really implore you to be adherent to your own care plan. Other aspects include, and this is the DPH side, once a case is referred or petitioned, DPH does an assessment and evaluation, and we have sort of a assessment and evaluation team at the ready. These are pretty much exclusively people who are being borrowed until we can complete hiring. That team will do an assessment and evaluation to determine both people's eligibility in terms of these, pretty narrow criteria, and also likelihood of benefiting from the process. What is different about our other procedures also is that the breadth of who can refer is broader than other programs that I just mentioned. So parents can refer, healthcare workers can refer, first responders can refer, and we, the court, is responsible then to consider the petition. And if the person is eligible and is likely to benefit, to undertake making a care plan, which we are DPH is responsible for. The person is also entitled to a care supporter, so of their choosing, who is I don't know, we don't have huge models for this, a peer worker, a accompanier, a friend who is their, walker in this path with them. And that
would be like a license.
But they also get representation through the public defender.
Importantly, thank you, the court boxes, yes, and they are represented by, I'm looking at Annie who's nodding at me, by a public defender. Did I forget anything, Annie?
There are two things. It could be, the public defender is sort of like the backup. There are these legal services nonprofits that get first dibs, and if they can't take the cases for whatever reason, then it's a public defender who steps in to represent the respondent. Yeah.
Right. Thank you.
Chair, I'm gonna, we do an agenda time check.
Are we past time? Is that what you're saying?
Yeah.
Yes.
I think then we can move on.
Yeah, so we still need to do public comment on this. I'm saying that out loud to make sure we don't forget. But just to see what we want to do next, we have, I think, 3 or 4 other agenda items left. And wondering how you all feel about what to keep and what to maybe move to next time or something like that. So we have the SCRT resolution. We have the progress report planning, which I think Jen or Valerie, you were gonna lead that. And then we have optimal use of IWG, which I think we're suggesting to move to a discussion group. And then we also wanted to plan for our next meeting, and Valerie has that.
Yeah.
So could I suggest?
Valerie's gonna add something, just a sec, Jen.
I just wanted to know that I see that member Fields has his hand up, and I'm not sure that we gave him a chance to speak. So So we allow member appeals to speak and then we will,
Thank you.
then we'll strategize about the remainder of the agenda so that we can get you out on time.
Thank you.
Oh, is that the cue for me to go?
Yes.
All right. I'll be unusually quick, I think. I just have a couple of quick questions. Thank you, Dr. Cummins, for the report. I'm really interested in seeing the care court thing played out. I did watch our governor on 60 Minutes Sunday, and I think San Francisco's dealing, as the law itself deals with, a lot of contradictions that aren't worked out. And I think the major one is the consequence model for people who refuse to cooperate with the court. And the second thing is the relationship to the fact that that whole 60 Minutes thing, in terms of the governor of California, no mention was made of the LPS Act. And I think that's the problem with integrating care court with existing state law, is how those two operate together. So the worst thing that could happen is we have a public that's now been set up to believe this is the answer to everything. And the governor more or less put it that way. And if it doesn't work, it's going to be the faults of the counties, because he also made it clear, hey, I'm not the governor of the counties, I'm the governor of the state. So if it doesn't work, it's on the counties. So we're under a lot of pressure here to work out those contradictions. And I look forward to working with the department on the implementation of care court. Two quick things, and maybe one of them you just have to pass on, but I would like if the IWG could get a report on the number of administrative days that are billed out on the inpatient unit at Zuckerberg General for behavioral health care in relation to acute days. It's always been an important indicator of looking at where we may need to have an outlet, so that we're not, it used to run at 60% or more in San Francisco. And I'd be interested in, it used to be a public report. Progress Foundation used to receive it every month. So we could evaluate whether or not we're utilizing acute care beds that are valuable and hard to come by, with people who are getting reimbursement from the federal government only at the admin day rate rather than the acute rate. Is it possible to get that data from the department?
I will find out.
Yeah.
Yeah.
I appreciate that. It's a good part of planning to see where our log jams are and where we may need, alternatives, because that's an expensive underwriting of acute care if a high percentage of our patients on the inpatient beds are only being billed out at the admin rate. So if you can, I'd appreciate that. Thank you very much. I'm done. Thank you.
Thanks.
Yeah, so
There are more, yeah.
yeah, so there's
Yeah.
yeah, so could I just make a suggestion as far as our time? We have 15 minutes left. We did have, as Diana mentioned, we had those elements that we still need to work through. From where I stand and where I sit, maybe we can handle the progress report planning very briefly, in the sense that we have an extension for the progress report and it is not due until December 3rd or December 1st. So we have some time, so we can start working on that, and we will ask for some participation for those who want to help craft what that is, because we are on tap to help develop it and write it, but we would like some feedback. So that'll be a discussion group that comes out. The optimal use of the IWG was another yes.
I'm so sorry to interrupt you, but I think as a matter of just public procedure, we have to take public comment on the director's update first before we can start.
Thank you. Okay, sorry. Yes, thank you. Appreciate that.
You had asked about the agenda order.
And
Oh, got it. Okay. Got it.
Yep.
Public comment on the director's update. So folks who would like to provide public comment, you could do so in 3 ways, either in person, or if you're joining by video, please raise your hand. If you're joining WebEx through the phone, you could press pound and then pound again and star to raise your hand. If you're on video, we will unmute you when it is your time to speak, and everybody will have 2 minutes to speak, and we will let you know when it's 30 seconds remaining. I'm going to move over here so I can see who's raising their hand online. Is there anybody in person who would like to make public comments? Seeing none, I'm going to, how do I get back to seeing the people? The participants over here. Oh, do you see anybody raising their hands? Nobody is raising their hand. Can you click the view all of the attendees? Okay, nobody is raising their hand online, so I think we can close public comment, and then I believe, looking at Valerie to make sure we can go to discussing the agenda.
Okay, thank you. So let's go back. Thank you for that, Valerie. So the progress report, we're going to be looking for a discussion group to help us craft that. For the optimal use of the IWG, that's really the structuring and the comments, you know, that will continue as a discussion group. So those slides are pretty self-explanatory and offer some of that feedback. And then, and we want to leave time for agenda setting. I do think that we have had this, the resolutions for the street crisis response team. I do think we should handle that today.
I agree. That's been going on for so long.
Okay, thank you. Thank you. So Chair Short.
Theoretically shouldn't take too long. Okay, so that's about it then, right? On what we have time for?
Yes. So just making sure we're gonna do the SCRT resolutions, which is discussion item 5. We're gonna skip discussion items 6 and 7 and put those into the post meeting email, and then we will close with talking about the agenda for next time.
Okay, and I think we're gonna have to once again consider if we need more time for these meetings. So this seems to be happening.
Are we
a fair
at
amount.
12 o'clock today or what?
Yeah, I thought it was 1 as well, but no, it's 12, and that's the problem.
Okay.
Are we gonna play today?
Yeah, just the 12.
I mean, I think we'll probably go a little bit over, but
Maybe I should have taken advantage that I was thinking it was the 1 we could.
Still one.
I think, sorry.
Okay, so let's do this. So
Not bad.
the pressure's on it. Yeah, goes a little over, okay. Okay. It says 11:42 anyway, no.
You gonna lock the door?
So people know the history of this, I think, but there were some changes made to the street crisis response team, and there were concerns from this body about those changes, and we wanted to memorialize what those concerns were, and also encourage some action on the part of DPH and or whoever had, DM, whoever was calling the shots at that point. So I'll just quickly read let's see, well, we did this last time, I believe. I'll recap the updates really quickly, which is that we did, whereas the decision was made to remove licensed mental health patients from the skirt bans with no request for input from the IWG, as learned in the SF Chronicle. That's what that paragraph reads now. The other paragraph that was changed is whereas the IWG understands that skirt vehicles dispatched to respond to behavioral health crisis calls currently have no personnel with advanced behavioral health training. So those were the changes made, but the resolution as stands now with that, the skirt team includes professionals on the vehicles. I'm sorry. The IWG recommends and urges the following. So there was, if you remember, there was a whole sort of preamble with findings, that kind of thing, but this is just the sort of action section of it, correct?
True.
So urges the following. Skirt team includes professionals on the vehicles with mental health training and experience needed to respond to crisis on the streets with a behavioral health and trauma-informed approach. 2, the focus of SCIRT continues to be intervening with people experiencing a substance use or mental health crisis on the street, with the goal of engaging them and having them enter into a system of treatment and coordinated care. 3, departmental oversight of SCIRT will include resumption of regular reports, which include encounter data, demographic information, disposition, and follow-up. This includes a regular sharing of data along with quarterly reports and discussion with MHSF implementation working group. And then 4, an evaluation of SCIRT is conducted annually and reported on to IWG and city stakeholders. So you like to do this temperature check thing, right? Want to take it? Jen's the one who likes to do it. You do it. Temperature check. Take our temperature, Jen.
Right. So how, let's see. Well, I would like to take the temperature, but I can't see everyone's hands. So Diana, I'm going to ask you, the way that we do this is we take a temperature to see if we're ready to vote on this and just get a feel for where people are. So remember that you're going to hold up your hand for 1. If it's no way I block this, up to 5. I love this and all the gradations in between. If it's a 1 or 2, we'll talk. So let's just leave it at that point now. And can everybody please hold up your hand, including you, Steve, if you can go on camera and let us know. Steve Fields would like to know what you are, if you are ready to, how you feel about this resolution. Do we pass it or do you block it? Hold up your hand, please. And Diana, will you count?
How many? Yeah. Fingers. About how many fingers? Okay, yeah.
Yeah.
1, 2.
What number are you on this?
Amy, I'm not seeing your fingers.
I'm fine with this.
Do you have fingers?
Steve?
And Steve, I can't see your fingers.
I can see my fingers. I'm just trying to understand, are we voting one of the 5 choices or up or down?
Yes.
Right now we are seeing where
whether
we
we're
are.
even going to vote on it. Yeah, of course. Yeah.
Put up the number of fingers
See my
corresponding to
fingers?
what, like 1, 2, 3, 4, 5 fingers.
Okay, we have 0 fingers that are a 1 or a 2 fingers.
Okay, and Steve, did I see your hand go up?
Which Steve are you
I'm being-
talking?
I'm sorry, I'm getting talked to because
Yeah,
I've got a
I know that
noon
feeling.
commitment. So I'm sorry, what do you need from my fingers at the moment?
Where are you in regards to this resolution from 1 to 5? 1 is no way, I hate it. 5 is I love it.
I'm 4.
You're 4. Okay, so
Okay.
everybody is at 3 or 5, so let's move on to a vote, please. The formal vote.
It's awesome.
Wait, first we actually have to do public comment before we can vote.
Before we go into public, can I just get clarification? Because I think with the SCIRT, right? I mean, I think they started it with the SCIRT team. Then I think I mentioned that I saw the truck as the WRT, which is Wellness Response Team. And then just recently, I seen the truck called Street Response Team. So do we have these names kind of keep evolving, changing? And I mean, I thought that with this mental health SF, we are to known it as a SCIRT team.
Under mental, key component of mental health SF as legislated was the street crisis response team. Separately, the street wellness response team was created separately. Part of the reconfiguration of SCRT was to combine those 2 teams. The intention was to keep the street crisis response team name, but I think some of the existing vans, et cetera, probably have not been made over to reflect the new name.
To the SCRT.
Yes.
I see, got it. Okay, thanks. Because I keep seeing all these different, I say, well,
There are a lot of different teams. That's part of it. And we're just talking about this one team.
Because that's the only one on the mental health SF board.
okay. Boy, it's kind of confusing. It's the same kind of the feature, the
I know what you
color,
mean.
whatever. And then so I'm looking at it and say, okay, are they changing it or are they?
Well, that is related to what we're talking about because they have been changing things, right? And so with this one instance, there were changes made that we are weighing in on now. So let's weigh in on this.
Who added this wellness name?
Who added what?
DPH, it was separate from, so there's only one team that mental health SF covers,
The skirt.
the SCIRT team. That was a separate team, but it's now melded into our team. So we're only talking about our team, which is the street crisis response team. But they merged.
We don't have, so So are we voting that they merge or?
No, so they made changes and, we are responding to the changes they made by, asking for some things from them because as a result. And the things I just read, so they're basically about reporting and accountability and also making sure that there's still mental health people of some sort on the teams. Because one of the big changes they did was to pull all of the mental health clinicians off of the team.
Wow.
Even though it's a mental health crisis response team.
And Sarah,
Well, we can't rehash it, I don't think right now.
and there's a proposal to get an update next month.
Uh-huh,
That's in the meeting planning,
okay.
that there'd be,
Oh, I see. So they will come and
oh, you're gonna have to make a report.
we're gonna have them,
Spending money.
so we're gonna have them here to discuss all this with us, it sounds like.
But you have to invite them.
Yeah, okay, okay. I will.
That the teams got taken out from DPH under the purview of DPH and put under the Office of Emergency Management. And so once they went to the Office of Emergency Management, they felt that they no longer had the same responsibilities on reporting and whatnot to us. And so we're trying to say, no, you still do, because this is a mental health asset program. And so that is what we're asking.
Now they're gonna try to move it.
I'd still stay under my Office of Emergency Management. That's not what we're saying. They just have to still provide us the data and come report to us as DPH did previously. That's all.
We're responding to that.
Yeah.
Yeah.
That's what we're voting on?
Yeah, so the resolution is up there on the slide again. So the one that they just talked about is number
So
3.
that was the
Data.
key thing, and the other key thing is the removal of the mental health clinicians from the teams, which some of us were quite upset about. So I don't think we can do a lot more rehashing and discussing right now. But yeah, just because we have been putting this off for so long. And as I said, I will definitely do my best to have them come to our group next month and report, and then we can ask them all the questions we have. So we're gonna do the vote.
First, we need to do public comments.
Please do that first.
So members of the public who wish to provide comment on this agenda item, which is discussion item 5, resolution for the street crisis response team. You could do it in 3 ways. I will first call on those who are in person. And then if you are joining online, if you could raise your hand and we will unmute you when it is your turn to speak. If you are joining by phone, please press pound and then pound again and *3 in order to raise your hand. Everybody will have 2 minutes to speak, and I'll give you a 30-second warning when your time is nearing completion. Anybody in person who would like to speak? Okay,
Can you say?
I don't see anybody in person. I don't see anybody. I'm gonna refresh. I don't see anybody joining remotely who has their hand raised. So I think we can public comment and move to the motioning.
Okay. So is someone making a motion to?
I will
Will
make a
someone?
motion. I will make a motion that we proceed to vote on the resolution.
So can you make a motion to approve the resolution?
Oh, to
We're actually
approve
voting,
that,
yeah.
okay.
Yeah.
I would like to make a motion that this body approve the resolution on the street crisis response team.
Exactly. Thank you.
Sorry.
And then we need a second, okay?
Second.
And then you're gonna do roll call?
Yes, I want to do a roll call vote, and if you say yes, you're voting for the resolution, and no, you are not voting for it. Member Fields,
Yes.
Member Gonzalez, Member Hammer,
Yes.
Member Lipton,
Yes.
Member McGuigan,
Yes.
Member Patterson,
Yes.
Member Salinas,
Yes.
Member Short. Member, an enthusiastic yes. Member Wong.
Yes.
We have 9 yeses and 0 nos, so we have a majority to approve the SCRT resolution.
We did something, guys.
I still want to applaud our very democratic process here. Thank you.
That's important too.
That's how democracy works sometimes, yeah.
All right, folks. So we're skipping over the progress report. Please know that you will get an invitation for that if someone would like to join us to comment. Otherwise, we'll bring it back to the October meeting. We're also skipping over the discussion group about the optimal use of the IWG. That group will also continue to meet, so you're welcome to join that. And I believe, like, if we could go to public comment and then we'll do some housekeeping, which includes agenda setting.
Yes,
And
so we're-
also note, I just want to note, like, it is 12:04. We want to be respectful of people's time. Like, if you have a hard stop at 12 and you need to go, please do.
Okay. Yes, public comment for matters within the jurisdiction of the IWG that are not on the agenda. If anybody would like to comment on this from the public, same way that you were commenting on the other things. So I'll first call on the in-person people. Attendees from WebEx can raise their hand. If you're calling in, pound, and then *3, and you have 2 minutes to speak, and I'll give you a warning at 30 seconds. Is there anybody in person who would like to publicly comment? I don't see any, so I will look at the attendees and refresh. I do not see any hands raised from those joining us online. So I recommend that public comment be closed, Chair.
So I close public comment, is that?
Sure, we can move, yeah, I closed it. Public comment is closed and I'm passing it back.
Oh, I thought you were saying you recommend.
Yes.
To me, okay, got it, sure. Okay, so now we're doing agenda setting, or it looks like.
Yes. Maybe we can do why don't we go back one, just because I know this is top of mind for many of the IWGs. Valerie, we are in progress, is that right? Is there anything you'd like to add to this slide?
Sure. So I have some updates on membership. I'm actually still receiving applications. I got one this week so far. We have started to get a little bit more diversity of applications, but I have still yet to receive any for seats 8 and 9. And there is a person who applied for number 5, who I think I could encourage to apply for seat 8. However, we are still missing applications for those 2, for 8 and 9. So I'm sharing with this group, I do need recruitment ideas for where we might list it. And we have a few names that I'm going to run down, just people we know, but I would appreciate help in sort of spreading the word.
The provider group, but does the provider group still need it?
Yeah, I think you guys did announce it, because I don't go to the provider meeting, the program director does, but she said you guys announced it in the provider.
So that
I did reapply in the end for seat 7.
Yay, yes, and experience stuff. So
I mean, it's because Emily passed away, who was gonna apply. So, I mean, it's under, I feel like horrible circumstances, but I did reapply for 7. Sarah has been doing some recruiting for 8. I'm not sure what. I know that somebody else applied for the seat 7, though, that could also probably qualify for 8, that you recruited. So I'm not sure, maybe it's a bit of like, we need a shuffle.
yeah, I think so. I was gonna review the ones for 7 and 5. We have a couple for 7 and see if we can encourage them to change.
Is it okay to be? Well, no, I'll talk about
So
one.
they need, folks need to designate which seats they want. So I would need their permission to reshuffle it, but. So those are the outstanding ones. I think that a couple other outstanding issues is that I've received a lot of applications in general from folks who are DPH employees. There's some concerns from the city attorney's office about seating a number of these seats for DPH employees. That presents an HR concern for compensation. That's because while participating, other than the seats that are noted specifically for DPH, they may not be able to be compensated for their time. So we're trying to resolve that. I've been calling candidates to discuss a little bit about the group and make sure they're comfortable moving forward. couple of folks who applied for the lived experience vacancy were not interested once the time commitment and lack of compensation for the seat were described, and I think that's an important consideration. I want to acknowledge, I know we need to continue to think about how long this meeting it is. It is one of the reasons I've recommended we shorten the meeting, is that just the time commitment for recruitment has been a little bit challenging, but so my proposal would be to ask the Rules Committee for us to advance with what we have and continue to work on the other vacancies, but getting 2 more seats filled, which we can easily do at this point, I think is worth doing, and enduring the time delay for getting the other 2. So that would be my recommendation. That's what I'd like to see. That's my membership update. Please send me 8 and 9, folks. So.
Thank you. Yeah.
One quick question on seat 9.
Yes.
Because it's a very, I don't think the number of qualified individuals is very narrow, because residential treatment program management, in one way, in terms of San Francisco's doing it, is really 3 agencies that, deal with the population that's defined in the law. And I'm one of them, and I'm already on a seat. Vitka Eisen was in that slot, I assume.
Yes.
That's the slot Vitka was in. And so that takes Health Right 360 out. And
I said it was number 5.
was that from, okay, that
Otter
was,
Rye that was in that seat, and since he's been gone, it's been vacant.
But anyway, Vic's the other person that could.
yeah, well, I don't,
Could fill that, but
Can we switch those off?
Do you want to
So-
apply for 9?
so what I was going to say is the status of PRC Baker Places, which is where Dr. Arise came from. I mean, they're still in the system. They're still providing services. That would be a mayor's office decision, and the agency's decision whether there's somebody. Their executive director's not come out of the residential treatment world, but I don't know. We might want to make some special outreach to PRC to see if there's somebody in their clinical operations system that would be willing to do it, like Dr. Arise did.
I'm willing to check in with them if that's okay to do. Okay, I don't know.
Yeah.
Okay. All right. Thank you, Steve. Very good point.
And if they need to talk to somebody about their misgivings, I'm the one who can sell them.
Oh, no,
an
I will
absolute
not send them to you.
Wonderful experience of being on the IWG.
We're trying to recruit them on, Steve.
Yeah.
Okay, so now let's move to the next meeting. Looks like what we've got on the docket so far is the Soma Rise report back, the DM and fire department update on STIRT,
These are all potential.
which I'm gonna request. Analytics and eval, which seems general, and I'm not sure, do we have a more specific idea what that means?
I think I need to discuss with them. I do want to know, specifically, I know of interest to members, Salinas, they have updated their ICM wait time data.
Okay.
And.
So at least
in
that,
response to your feedback, and so that's something I'd like to have them bring back.
I think, okay. And then, update on the community engagement we heard about today. There are other possibilities that have been mentioned, staffing and wages study update.
Which I think can be ready for October.
Okay.
Oh, that would be great.
We actually already have community engagement on there, and then the progress report, which we didn't get to. So before we even think about any of those, are there any additional items that people would like to see on next month's agenda?
You guys will have the holiday scheduling, which is just a housekeeping thing.
I
Well,
think
this is for our,
holiday scheduling.
around Thanksgiving.
By that meeting,
Yeah, we should
do it for the following.
We're hoping to discuss it a bit today, correct, Jen?
Yep.
Yes. Yeah.
Sounds like good,
Because we don't want to meet on Christmas.
word Thanksgiving.
It's okay.
Jen has that in the
Tuesday.
shed, so it's gonna help
Yeah,
me out.
Yeah, so the issue with the holiday season is like we're mandated by the ordinance to meet monthly. the holiday season makes our end of the year scheduling a little bit wonky because both November and December meetings fall on the last week of the month. So for November, that's the week, it is not the week of Thanksgiving. So November meeting makes sense, but the December meeting is on Christmas Eve.
Let's do it.
And so
I think
we,
it's on the
we,
26th.
That's the day
we,
after Christmas.
Who brings the stuff?
Six, still.
so we will usually, so we usually have to reschedule the December meeting. But you know, the holidays, because the last meeting in November is pushed back and then we have to push up the December meeting, the time between the two meetings is very small. So, you know, there's a couple of different options. And Valerie, I'm wondering if, you know, like we could find a different time in December to meet, which would just press the meetings very close. We can cancel the meeting altogether. I think, Valerie, I think we can do that. That's a question for you.
I don't really have a problem with the meetings being close together because I think we have so much, we don't get to
Okay.
everything that I don't think we'll be short of items just because we haven't had enough time in between.
So have it on the 12th or the
Yeah.
19th.
I'm not worried about like the amount of items that are on the plate. I'm just concerned about all of your time.
People's time, yeah. There's
Meeting
that,
time.
yeah.
Yeah. So I think
As far
that's
as
it. It's
whether or
like
not we-
how you
Go
want to
ahead,
handle it.
ask.
Say that again, sorry.
So as far as whether or not we can cancel it, I'd have to ask the city attorney. It is a legislative requirement that we need to.
I prefer not to as well, because we have so much to do.
I have a question about the agenda for next meeting.
Yes, sir.
Is that your main?
Wait, so, sorry, we talking about the agenda for next time or the moving of the holiday one?
First, let's first finish
is
the
the agenda.
conversation about the meeting, about
Okay,
meeting.
schedule, and then we're gonna
schedule.
move back to the agenda.
Fine, thank you.
So did we settle that with the scheduling then? I think.
Could be the ninth. Sounds like people want to, I'm trying to summarize. It sounds like we want to keep both. So November will stay when it is, which is the 28th, the Tuesday after
Yeah.
Thanksgiving. And then December, it sounds like we want to move up
The 19th.
to sometime. And should we decide that now, the date that we want to move it up to, or is that like a doodle poll kind of thing?
So just do a doodle poll, but can everybody pick 19th, and that works for everybody, great. If not,
Yeah, we could definitely do a doodle poll. There's going to be a lot of scheduling things coming up, so we would have to ask you all to be very attentive to what those times are.
I think if everybody who's here right now says, hey, the 19th works,
19th
then
works.
we can just
yeah.
lock it down.
Jen,
We are not able, so as
With
facilitators, we
our-
are not available on that week of the
Yeah, we're not
18th.
available that week.
Oh,
Well, you're not available on the 19th.
We're not available that.
Okay, let's put that up.
okay, so we're gonna do a doodle poll for around that time.
So we're probably looking for something the week of the 11th.
Yeah, just,
Let's do it the 12th.
yeah, exactly, yeah.
12th?
Well,
I don't know
12th,
that it
okay?
has to be a Tuesday either.
It's a staff meeting, but I mean, I feel like.
Hard to schedule.
No.
Okay. All right, I know Steve has something on the
what
agenda.
about the agenda for next meeting?
Okay, so wait, are we moving to the 12th? Is that what we're doing?
I think we're gonna poll it.
Okay, thank you.
We're gonna pull it with yes.
Got it. Thank you.
My comment is we're here 3 hours and 15 minutes. We only really covered 2 agenda items today, plus the director's report. I'm not going to include the motion because that was a 5-minute issue. But I don't know how we're going to cover all these potential topics next month. In the time frame we have, and I just think we need to figure out, I'll defer it back to the chair to work with staff to figure out how to manage the time schedule so that we don't wind up having the same situation that we have today.
Yeah, and that's what this conversation was about, is prioritizing here. And making sure we had the whole universe of what people wanted to talk about before we, did that. And since I don't believe anybody added anything. So if you're looking at this list right here, I know what mine would be, but they also take different amounts of time on each of them. So I would say that the community engagement is really important, especially since we started on that. We want to have regular updates. I would say that the skirt report back, since we're really quite in the dark at this point about that, and we want to, get the momentum going with doing that, that those are sort of I wouldn't want to, lose either of those. And then we always have a director's report, let's remember, so that's sort of 3 items. And, which would be our most important after those to people.
I mean, I think we've been summarized.
Summarize.
We are, the staffing and wage study was supposed to happen in July, right, when we canceled, which is also, I think, been, staffing is, I mean, like we said, we can start all these programs, but if we staff them. But also, I think we should propose that we should meet for one, as has been our standard. But, I mean, again, those are huge, right? So staffing and wage analysis can take half an entire meeting in and of itself, so maybe we should put it for November. But make sure, I mean, if they can't come in November though, and they can come in October, then maybe we need to switch something that can,
Is that staff's understanding too, that item could take, like up to 30 minutes?
Staffing and wage would prefer November. I was just looking at their last.
Oh, okay, great.
So they can do October, they would prefer November.
Then let's just do for November. I mean, that's a huge.
And then knock back the agenda.
So
November.
we have community engagement, skirt report back, staffing and wages. And that, we leave it at that, and
Staffing and wages is November, not October.
yeah, we're talking about November.
Okay,
That's our next meeting.
okay, got it.
No.
No, next meeting is October. So we're in September now.
Yeah.
I know.
I'm gonna run my ride is waiting.
Okay, thank you.
Thank you.
So maybe it's just what we see here, but move analytics and evaluation to November. Right? And then do everything that's there.
Yeah, thank you.
So the box on the right is November.
Okay.
The box on the left is October. That just moves analytics and evaluation.
Got it.
We'll repeat this process next month, so then merging fees for November.
But once again,
I am.
Valerie, we can't hear. Can you get closer, Valerie?
Oh.
I said that we will repeat this process each month. We can update November agenda needed when we get to October.
I can't hear you. Can you speak up again,
He
please?
said we'll repeat this agenda setting every month.
All right, thank you.
We just have a couple of slides left, folks, just
Sorry about that.
2 minutes.
Okay, let's close this out. So next we have, are we
Yeah,
talking
and share
about, like,
short.
Group
Share short,
surveys?
just-
Yes?
I want to really plug, we got this community engagement, meeting structure and progress report. We have 3 different discussion groups plus another scheduling of this meeting. So please look out for that post-meeting email and fill out those different opportunities.
Will do, thank you.
Take care.
Okay, then. There's some more committees you can attend, folks, all right?
So,
Okay,
Should do adjourn.
do I just say, words adjourn? Oh, it's on my script. Delay everything, I mean,
Yeah, you have to say the word or we're never adjourned.
everything's on there.
You're the one who has to say the word.
Okay, does anyone want to entice me to say the word?
I said motion to adjourn.
Okay, we need a motion to adjourn.
I motion to adjourn.
Okay, second.
Second.
Okay, you are adjourned.
Yay, thank you.
Sorry, I'm getting all power.
Thanks, everybody.
Getting all power trip.
You survived.